Just bear with, we're just sorting the live stream out.
So just tell me when you want me to start.
Okay, what I will start the webinar and then we should be good to go. So I'm starting the webinar now, and we've got about 70 people in there. Right. So give it 1 minute, Jimmy, for people to join.
Okay.
Okay, we're good to go, Jimmy.
Okay. Hi, welcome everyone who's online at the moment in this APEC webinar on the World Pre-eclampsia Day. I hope you're all sitting comfortably because I think it's very exciting, the discussions that we're going to be having. I want to, first of all, just to introduce myself. I'm Professor Jimmy Walker. I'm the Medical Director of APEC. And I want to hand over now to Marcus Green and Professor Andy Shannon to talk about APEC itself just for a minute or so.
Hello, I'm Marcus Green. I'm the Chief Executive of Action on Pre-eclampsia. I'm in my 10th year of doing this role, and I'm absolutely delighted that we're partnering with a number of organisations to make this happen tonight, this afternoon. A warm welcome to you all wherever you are in the world. I know we have over 500 delegates signed up for today, so I hope you find it an informative session. APEC is the UK charity for pre-eclampsia. We were founded over 30 years ago, and we're predominantly involved in 3 areas. The first of these is supporting patients. That's probably the most important thing that we do, and one of the things that we're really solidly about. Second thing is we provide education resources for professionals, and for midwives who want to learn more about pre-eclampsia, we do a course. You can find it on our APEC website. It is free and CPD accredited, and you're warmly welcome to join that. The third area we're involved in is research. Cutting edge good research is what makes a difference in pre-eclampsia, as we all know, and that is why we are heavily involved and give the patient voice. And at the heart of everything we do is the patient, and we'll be hearing from patients today, and we'll be hearing from a whole load of clinicians. But I will just hand over for a moment to Professor Andrew Shannon, who is our Chair of Trustees and runs APEC International. Andy.
Right, just wanted to say welcome everybody. It's great pleasure that so many of you to be able to host this, and that it's remarkable that so many of you have taken the time to register and come and join us. I think we've got a really exciting group of people to discuss things. I'm going to be giving a talk on basically some very exciting tests that have been developed in recent times. That's a sort of nice move change in our understanding of managing pre-eclampsia, and I hope you'll be able to listen to that. But following on later, we've got a really remarkable group of people from all over the world who can share some of their experience in this incredible disease. And I think we're making some really good moves forward in the area.
Thank you very much, Andy.
Okay, thank you very much, Marcus and Andy. We've got a very tight schedule today, to start, we've got a very interesting discussion led by Alex Ridout, who is a ST7 in obstetrics and gynecology and a clinical lecturer in women's health, who's committed to improving outcomes in women globally. And she's going to be talking to Professor Lucy Chappell. Now, Professor Chappell, I remember as a young keen researcher in preeclampsia, and she is now the Chief Scientific Advisor to the Department of Health and Social Care in the UK, and with overall responsibility for research and development. And they're going to be talking really about sort of the preeclampsia, the science, the policy, and the practice. So this is a recording, so they get started with that. Thank you.
It's an absolute pleasure to be joined by Professor Lucy Chappell today. So as I'm sure you all know, this is the UK's Chief Scientific Advisor for the Department of Health and Social Care. She is an internationally respected academic in obstetrics and maternal health, but also just a phenomenal mentor to us all. In this conversation, we're going to talk about science and policy, how they connect, and how we move research from just, the lab, the bench, the real world impact. I'm touching a bit on maternal and global health as well. From your point of view, how scientific advice advances, be that screening, prediction, in any of those areas really help shape national or global health policies in these areas?
Thanks, Alex. Thank you very much for the invitation. I'm very struck that you're in Sierra Leone. I'm in St Thomas's Hospital. Women are broadly women the world over, and there's so much that we can learn from such dialogue. And so it's very appropriate that we're doing it in these two places. How do I see that linked to science and policy? Well, I thought I might give a few examples where we've really seen the impact of research translating through. And the first one, I think, is you touched on the maternal mortality. If I think about the confidential inquiry into maternal deaths and how much it teaches us, not so that we just stop and admire the problem, but so that we actually understand where interventions make a difference. When we reviewed all the maternal deaths, we could see the real impact of free antenatal care, guidance on antihypertensives, guidance on managing cerebral complications, which then led to corresponding changes. And I think that really brings it home from a population level down to the women that matter. The second example that I'm going to use is aspirin treatment. That went through evaluation, randomized controlled trials of a drug treatment in pregnancy. We took the women with us. It's crucial that we do that. And we now have an evidence-based prevention treatment for preeclampsia. And the third area is diagnostics, because we've seen huge leaps in the opportunities for diagnostics to really change care and change outcomes. And actually, we're also seeing how this gets enacted in many settings around the world. So, for example, the work that our group and many have done on placental growth factor-based testing has changed how we provide care for women in so many different settings.
Lucy, you touched on Piaget, and I think that's such a beautiful example of how you've actually taken the science and put it into action. But we all know that implementation gap between discovery and real world change is huge. It's such a hard focus for us researchers. So what are the key factors or learning that you have thought or have accumulated that really kind of will help us to bridge that gap?
So I think what I've really seen since I've come into this sort of wider government role is the crucial importance of involving the end users at the beginning. And so I'm going to start with the most important group of end users, which are women themselves. We have seen the strides that so many research groups have made around the world in terms of community engagement and involvement, public and patient involvement and engagement, and how that completely transforms research. You can see it through priority setting partnerships, through involvement at all stages of the application, the delivery, the dissemination. This is not tokenistic. This has got to be real through multiple routes. And I think it has done so much to change our research. The National Institute of Health and Care Research is the R&D arm of the government department in the UK. We have embedded it across our programmes. The second aspect of this, which is just as important, is research inclusion. So that is saying we are asking researchers to involve patients in the public who are representative of the populations where we are seeking to implement, because we can't expect implementation to stick unless the research is designed and delivered in those very populations with additional work to ensure that that population is represented. And so we've now made it a condition of funding in our awards to show that we are really serious. And then the third is an area, I used to think my job was done when the paper was published. And when I got a Lancet paper, I was particularly happy. Now I realise that that paper being published is just the first of the next step, the next chapter. So I think, look at all the ways to involve commissioners, policymakers, guideline writers. And actually, Alex, I would reflect back how you're doing that in Sierra Leone, with the ministries, with the local commissioners, and what difference that has made to not just the research, but the likelihood of adoption. I don't know if you've got an example from Sierra Leone where that's really come to bear.
Yeah, Lucy, I think that is exactly what came to my mind, actually. So, you know, when we started doing the cradle research in Sierra Leone, it wasn't that we went to the government, we went to the ministry, it was actually that they came to us. You know, at that point in time, 1 in 5 health facilities didn't have a blood pressure device that works. That is completely unthinkable for us in the UK, but that was the reality for them. And they needed something that was robust, that was cheap, but actually made impact. I'd love to hear from you what you think the most urgent research priorities are in this setting. So, you know, around pre-eclampsia, and completely up to you whether you take a global stance or a UK stance.
So I was thinking about this, and it would be possible to divide it in all sorts of ways. So you could divide it by sort of therapeutics and diagnostics. You could divide it by pre-pregnancy, in pregnancy, post-pregnancy. But I think actually one of the really useful ways to think about it is addressing the inequalities, because I think that will give the research the focus that it needs. And I think if we have inequalities even more strongly woven through what we do, we are going to do research that matters. The other flip side of this is research that has got very clear outcomes that matter. And I think of a couple of examples of this where I think about the really exciting opportunities where we leapfrog in innovation. So interestingly, the real push on point of care devices has come through the application into global health settings where highly centralized laboratory facilities are just not how care is always delivered. And similarly, if we think about AI-driven ultrasound, where there is a need for accurate gestational age, or it's about what is the purpose of this research. So I think those focuses are then applied into all of those other areas. And rather than having a single special child for a priority, one of the things is how do we improve outcomes in the round? And it comes on to something about that need for interdisciplinary research that really draws on, I've seen it in first hand across many groups where you get qualitative mixed with quantitative, and where the outputs and the outcomes are so much stronger as a result. So it's about that inclusive approach to research that really drives improvement.
I guess the other thing about you, Lucy, is that you're a phenomenal mentor, and I think a huge success in your career. And I guess, you know, as us early career researchers or doctors even, you know, think about our career and how we best become a leader to our patients, to our colleagues. You know, could you give us a bit of advice that you've learned along the way?
Well, one of the things that I'm really keen to get across is that I'm in a position now where it would be easy to think I have a straight line from, you know, my medical school to this. It has been so far from that. And so I have had a real zigzag journey through clinical roles, through academic roles. I've done some editing on the side. I've worked for the grant funder for the NIHR, and now I'm leading it. So one of my sort of one of the things I would say is be open to opportunities. Sometimes they work and they're amazing. And I know that many people on this call will recognise that. Sometimes they don't, and that's okay. You can find your way back to the main road and find something, but you might well have learned along the way. So I think that has been one of the things that has really helped me. The other thing is those mentors that you talk about. And I say mentors and sponsors because I've had people in my life, I'm going to call it Angie Shannon now, for being so pivotal in sort of being that support and being there. And I am really clear that I am willing to learn from others. I learn from all of the members of my group. They might be a medical student, they might be a PhD student. So being that atmosphere and that environment of challenge and be challenged is one of the most exciting things I think about science. And we have to think that in a cultural context as well, but to really encourage what I think of as that curiosity that can be so inspiring, because it's what inspires me to get up every day and make a difference. And I try and share that with the group and really bring people on that journey.
Yeah, which actually takes me perfectly to the next question, which is actually about the fact that you are not only all of these incredible things but you're also a phenomenal clinician, and you run a really high-risk clinic in St Thomas's Hospital, the high sensitivity and pregnancy clinic. So I guess maybe talk a little bit about that, about the ethos of your clinic, and how you fit it all in. It's a miracle.
So even in this sort of government job, I come back to the hospital on a Wednesday because it is one of the most grounding experiences. And when you're sitting in antenatal clinic, the woman opposite me just needs me to be a competent clinician. She doesn't care about job titles. She cares about the care. So I share the clinic with a team, and we are definitely a doctor team and a midwifery shared team because we provide care together with the support of many other services. My ethos is that we provide holistic care for women, not for numbers. Just because it's called a hypertension clinic does not mean that I look after blood pressure. I look after women and provide care for them. And I think that is critical because then that empowers me to look after all of her needs, not just what drug she's on for blood pressure. So I often start a consultation by saying, what's important to you today? What would you like to talk about? And letting her set the agenda.
Yeah, no, thank you so much for that. I'm just super interested in a kind of final question for you. Is you have these different hats. I just wonder how that's going to change your view of pre-eclampsia or just women's health more broadly.
So I would reflect that I'm very clear that I've brought my learning from my experiences over all these years in women's health to much of what I do at a government level, whether it's thinking about the global impact of what we do, whether we look to design and deliver research that addresses the greatest needs, and then also about how we use innovation to really drive better outcomes.
Incredible. Kathleen Chapel, thank you for sharing your reflections and your experience. You are an inspiration to us all. And we are all here together to really, drive change for the women and the babies. And as you mentioned, that is really what's central to what we're doing.
And Alex, one thing is that we will be judged by the legacy we leave behind. This is not about personal, what we do from a personal level. So the fact that we can reach so many and our impact will be through the next generation. So thank you to you for your sort of emerging leadership, but also encourage everyone on this call to think about what they can do and achieve in their setting, and then how they can encourage those who are coming up to share the same vision that so many of us have. We're on this call today for World Pre-eclampsia Day because we're striving to make that difference, and then also bringing on the next generation, whether it's here or in Sierra Leone or so many places around the world.
It's an absolute pleasure to be joined by Professor Lucy Chapel today. So as I'm sure you all know, this is the UK's Chief Scientific Advisor for the Department of Health and Social Care. She is an internationally respected academic in obstetrics and maternal.
Sorry, the video had started up again. Jimmy.
Okay, thank you very much. And I think you hopefully have got a very good sort of wider view of pre-eclampsia, having listened to Lucy, who's talked about lots of aspects of it, both from her career and her experiences. And certainly as a senior clinician in women's health in this country, I'm very pleased that Lucy's in the position she's in to help lead advances in women's health in the future. And people like Alex, who are the people coming through who are at the stage that I remember from first meeting Lucy. So as people move forward, we'll be revisiting some of these subjects which Lucy talked about throughout the rest of the day. And the first one is that she mentioned the placental growth factor and the role of placental growth factor. And one of the important things to remember in all aspects of medicine, particularly preeclampsia, is that the idea of risk assessment and escalation and intervention are the three different steps. And one of the biggest advances recently has been this increasing knowledge of disease processes and looking at the prediction of problems and whether you then can get into early intervention. Now, Andy has been one of the main workers in this area over the last few years, and I'm very happy to invite him to talk on, at last, an easy test for diagnosing preeclampsia. Thanks, Andy. Oh, just before you go on, anyone who wants to put questions into the question and answer bit of flag in the webinar, please do, and we'll put these questions to Andy at the end. Thank you.
Great. Thanks very much. Thank you very much, Jimmy. And I just want to reflect what Lucy was saying. You know, Lucy was a phenomenal student, has now become a master. And I'm sure there's only a matter of time before Alex becomes the master. But just to kind of say to everyone, you know, nurturing others and building a legacy and a team is probably a much better way to influence the world than you'll ever do yourself. So I just want to kind of acknowledge that. It's actually a great pleasure to talk about this topic of this new angiogenic marker test that we now have available to us. And I wanted to take the next half an hour or so really to go through some principles about pre-eclampsia, its pathophysiology, and how it influences our management and how we can make a difference. I just want to acknowledge that there are a lot of biomarkers out there. There are a lot of companies that we need to promote them and commercialize. APEC actually engages with all the companies. I have no personal financial interest in any of the work we do, but they are a very important part of the success of getting tests. And we've been working very hard to make sure that they're going to be accessible to the whole world, not just to high resource settings. I guess everyone on this call has got an interest in pre-eclampsia, and I don't really need to spend time reiterating the impact pre-eclampsia has. I think one of the things about pre-eclampsia is we haven't yet cracked that nut of how to prevent it or cure it. The only way really to get rid of it, as it were, is to deliver the mother, and that has implications for the baby. And there are many, many babies that die and will continue to die. But there are some principles about preeclampsia I just wanted to go through. Firstly, we know there is huge inequalities around the world, and this is in the background of the fact that we don't have a cure. So what it tells us, of course, is that if it is managed well, the outcomes can be incredibly good. And this is a paradox because we sometimes forget how bad the outcomes can be, even though we haven't cured it. And so we have to look to around the world to see what's really going on with this disease. And even across high income settings, there are big variations in outcome. And this is largely attributed to access to care. So those countries that have universal healthcare provision, people get their blood pressure measurements and they get seen in a timely manner. The outcomes tend to be excellent in terms of very low levels of mortality. And even some high income settings with spend a lot of money on this, the poorer members of society who don't access care still have relatively high mortality rates. And I think this is important. I also wanted to share this slide. It's about to be published in BJOG, and it sort of reiterates the fact that most of the problems in the world, particularly in maternity, and if this particular slide looks at maternal mortality, you can see that the vast majority of deaths in maternal mortality are in the sub-Saharan Africa area. And this is, again, in the background of only less than 20% of the world's population being there, even though over 70% of maternal deaths. This is further confounded by the fact that the average age in Africa is a lot lower than the rest of the world. It's only 19. So the problem's only going to get worse. In the next 10, 20 years, the reproductive population is going to grow greater than anywhere else. And if we don't do something about this problem is that these inequalities are essentially going to get worse. The research we do is often in Europe or North America. You can see they represent a tiny part of the world's problems, for example, in preeclampsia. And, you know, Marcus, myself and Lucy wrote this editorial a little while ago when we had a huge success back in 2016 in the UK, when only 1 in a million women died from preeclampsia in the background of not actually having a cure. And this reflects the fact that if recognized and managed well, you can bring mortality way down. I wanted to share this data with you. This is one of the places we've been working in Sierra Leone, in Freetown, the main city there. These are 2 hospitals we work at, remarkable people doing remarkable work in both sites. They are both funded by the government. They both access government staff. they have the same populations that feed them. However, the mortality in one hospital is literally 25 times greater for the mother and 10 times greater for the baby. And so it's a lesson that even in the context of the same funding, the same staff, things can be a lot better through better organization, and it doesn't necessarily have to cost a lot of money. And I think we've learned a lot that simple things, simple cost-effective things can make a big difference. So it's about education and action as much as it is about resource. I think we have to think slightly differently about pre-eclampsia. Pre-eclampsia we've known about for 100 years or so, and it's come about to be characterized mainly by the blood pressure and by protein. But we know it's much more complicated than that. It's a body-wide problem. So essentially, it's a syndrome. And the definitions around blood pressure and protein are now a little bit outdated. And we can't be precise. And we do, unfortunately, get it wrong. So we can say someone has preeclampsia when they don't. And importantly, we think they're okay when they actually have preeclampsia. Just to illustrate this, I just want to show a couple of anecdotes. These are literally individual patients. So this is a woman who has her blood pressure done over a 24-hour period. You can see the blood pressure goes all over the place. It goes up and down, further confounded by the fact the way we measure it is not that precise. So in preeclampsia particularly, these blood pressure devices do underestimate the blood pressure. And equally, the other hallmark sign of preeclampsia, for example, proteinuria, if you dipstick one woman's proteinuria over a 24-hour period, you may get 2 pluses or a trace, depending on what she's been drinking, dilutional effects. And so you may be falsely reassured, or you may over-egg it. As it happens in this case, this woman did have significant proteinuria, but on 3 occasions, she only had a trace, which may have been falsely reassuring. And I think we all know as clinicians, those questions that about how do we manage this condition? It's quite difficult to predict in that woman who turns up with high blood pressure. Is she someone who's going to have a devastating, life-threatening problem in the near future, or is she going to be absolutely fine and have no problems at all? And we genuinely can't tell by the way she presents it a lot of the time. And equally, is her baby going to be fine? Is she going to have a stillbirth? And we do a lot of tests on these women to be reassured, and they're not all perfect. Should she be an inpatient? Should be an outpatient? Should she move somewhere where people are familiar and have sophisticated care in case she gets very sick? And perhaps quite importantly, how do you cure her? And that means when should she be delivered? This slide Chris Redmond gave me, he sadly died last year, but a great guru in preeclampsia, but I love to show it and recognize him because he made this very astute observation that preeclampsia starts very early on in pregnancy. We just don't know about it, likely to be related to placentation, the placenta implanting. At some point, you develop the signs of it, and classically high blood pressure and protein. You may or may not get symptoms. They're not a good sign. But what's pretty sure is that you can put your mortgage on the fact that you will have a life-threatening crisis in a relatively short time, maximum 2 weeks, and often only a few days if it occurs preterm. So the funny thing is, we do have knowledge that preeclampsia is there now with these blood tests long before it is. And the challenge has been, how do we actually take that into clinical practice to help the people we look after? The classic textbook progression of preeclampsia starts from normal pregnancy. You develop high blood pressure. At some point, you develop preeclampsia. It gets severe. You then get symptoms. You have a crisis that affects the mother or baby and is life-threatening. Unfortunately, life isn't quite like that. We know that early onset preeclampsia can be worse for the baby. And unfortunately, classically now, this classical picture is not that common. It can develop very rapidly and without warning. You may even have an eclamptic fit, without prior knowledge of preeclampsia, or you may even die from preeclampsia without having an eclamptic fit. So it is not that reliable progression that is in the textbooks, and there may be features that are misleading. On the background of this, we do have risk factors for preeclampsia, but risk factors you cannot rely upon to target the right population accurately. The typical one here is obesity. We know you're 3 times more likely to have preeclampsia if you are obese, but most obese women don't get preeclampsia. And most women who have preeclampsia aren't obese. So that knowledge is only a vague indication of who to worry about. And this data from New Zealand, from Robin North, shows that actually more than a third, and the commonest presentation of preeclampsia is in women who have none of those risk factors. So the biggest group, 37%, have no indication of prior obesity, family history, or hypertension, which are the classical risk factors. And a very simple statistical quirk, which is nothing we can do about. If you have a condition that has low prevalence, and for preeclampsia that is typical, maybe in 2 or 3% of people, might be higher in some countries, but nevertheless, even if you have a good test with high sensitivity and high specificity, you end up having a lot of false positive tests. So your test is abnormal. You quite often don't have preeclampsia. So you have to have a really good test to get it right. Now, Robin North, back in 2011, put out this diagram, which I think was very interesting. These were all the substances that were different in women who were destined or who had preeclampsia. And everyone has been sort of chasing this holy grail of what is that substance that tells us if you have preeclampsia. At last, actually, we have sort of found it, and that is the angiogenic markers. We know that when PLGF is very low, and S-FLIT goes up, and they do kind of interact with each other, so they are biologically related. This is indicative of risk. Way back in 2000, actually one of Lucy Chappell's PhD subjects, we did know PLGF was low. And we know it's low from early on in people destined to get preeclampsia. Once you have preeclampsia, it is very low. And the reciprocal is the same for soluble FLIT. So in other words, you get very high soluble FLIT in people who have the disease. And there is a wealth of literature out there now. Susie Duckworth published this from our group back in 2016, which showed when we looked at the 58 substances that were looking promising, that even if you took the top 8 of them, PLGF alone was almost as good as any combination that you could put together. And this was really exciting because it did mean you only need to do one blood test to get virtually all the benefit of a predictive marker. And again, there are many products out there, but what this ROC curve tells us is there's a very reliable point above which the test tells you you're very unlikely to have a problem. And there's another reliable point, which is low, below which nearly all the problems happen. So in other words, it is a very good rule out and rule in test. And if you compare it to what we used to do, which is take the blood pressure, measure the liver function, uric acids, it actually is a lot better. So this curve is telling us that the ability to predict whether you're going to need delivery in 2 weeks in someone who may or may not have preeclampsia, it is much more reliable than all those tests we used to do. And if you add in all those tests, they don't actually make the test any better. So the blood test alone tells us pretty reliably who's going to get preeclampsia. And if you look at this in clinical practice, this is one of our early studies. If you have an abnormal level, on average, you're going to need delivery pretty soon. So only about 8 days after you have the test. And this is a group of women who did not have preeclampsia. Conversely, if the test was normal, you would go some months. Essentially, it's saying that you're very unlikely to have a problem in the near future and probably the distant future. So this was very reassuring for us. And the final thing to say about that original data is it's not just you're picking out a very small group who are normal or a small group who are abnormal. In the average woman who turns up to a hospital in the UK, about a quarter of them were marked as being abnormal, and these all needed delivery pretty early, and about 40% were completely normal, and these all needed delivery months later. So in other words, it was a very useful test in clinical practice. And one of the early findings, which I think was incredibly exciting and important, was that if you look back at all the data, there were 7 babies that died in our first data set of a few hundred women. Every single one had an abnormal PLGF. In other words, not a single case was missed, even though in clinical practice, these cases weren't necessarily picked up in standard antenatal care. A very important principle is that there are lots of tests out there. And when we've compared them all, they are all good. So it's very difficult to say one is better than the other. They come from a number of different companies. This data from Alice Hurrell from the Parrot-2 study was probably the largest comparison of 2 tests, the ratio and the PLGF, in this case, the Quidel and the Roche test, and it was very reassuring to see that they're both equally good at predicting, are you going to need delivery from preeclampsia? Now, the next question is, what do you do? How are we going to use these tests in the future? We've done some studies looking at hypertension, and I just want to share with you some of the angiogenic marker tests from the CRADLE program. I think one of the CRADLE studies was we looked at 500,000 deliveries across a number of countries. And in that study, we demonstrated that preeclampsia represents about 22% of the deaths occurring. It's not the commonest cause, but it's perhaps the easiest one to treat because you can identify blood pressure and then do something about it. One of the trials we did in the UK was we delivered people a bit earlier from 34 weeks routinely to see if we could improve outcomes while checking that the baby was okay. And actually, it was beneficial to the mother, obviously, because that's how you make it better. But what was really important was there was no obvious clinical harm to the baby by doing that early delivery. And women were more likely to actually achieve a vaginal delivery, perhaps because the babies were stronger and healthier if they were delivered a little bit earlier. And this reassured our neonatologists that we were okay, although they still were taking babies to the neonatal care just to be checked, we believe. So we did the same study, Alice Beard-Morgray led on this in Zambia and India. And of course, this is where it really matters because there are many more stillbirths. And of course, removing the baby from the hostile environment actually is a good thing because the baby will grow on the outside. It doesn't have the sick placenta feeding it. You remove the risk of stillbirth, abruptions, and so on. But it may be immature. And what was really exciting about that CRADLE-4 study was, yes, we were able to prevent nearly all the antenatal deaths, and that actually represented 75% of all baby deaths just by routinely delivering 34. And there didn't seem to be a downside. However, it is still quite serious delivering a baby at 34 weeks in a low-income setting. And we do want to make sure we've got the diagnosis right. And this is probably where the angiogenic markers come in. In Sierra Leone, we scaled up the blood pressure device to the whole of the country. And I just wanted to show this slide to demonstrate just this really where it matters. There are so many deaths in each district. It's very hard to kind of replicate that in a high income setting. And this is where the benefit's going to be. So we're going to look at angiogenic markers. Now, we know the high S-FLIT, the low PLGF is that test that tells us. And what we've worked out is that the best place to use these tests is not early on in pregnancy, which you can do to target aspirin, not when you have preeclampsia, but in those you're not sure about. So the women who walk in with hypertension or who have other signs and symptoms. Kate Duhigg led on the first trial where we actually looked at the value of the test in clinical practice in the UK. We wanted to know how was the test performing, but more importantly, will it actually change practice that benefits the mother? And in a step wedge trial, yes, we diagnosed preeclampsia earlier, and it did benefit the mother. And based on this, the NHS decided to fund this and roll it out throughout the NHS. Here is the data showing preeclampsia is diagnosed earlier, and that there is about a 70% reduction in adverse outcomes, although adverse outcomes in this setting does not mean maternal deaths. There were other studies that were slightly different in Parrot Island, where they actually recruited a lot of people with just small babies rather than hypertensive. The benefit wasn't so clear. It wasn't significant, although there was like almost a halving, actually more than a halving of the babies dying. So it's probably underpowered, but looking good. And what we've learned from this is you probably should target this test to people who have hypertension or likely preeclampsia rather than IUGR, which of course can be a component of preeclampsia. Now, there are a number of tests out there that are recommended by NICE. And actually, there's now a different test recommended by the FDA in the United States by Thermo Fisher. And their more recent studies in 2022 are very similar to the early studies from Pelican and others in the UK. Essentially, you do diagnose preeclampsia earlier. It's much better test than all the old tests we used to use. And you know, very consistent message. And in fact, some societies like the ISSHP have now included angiogenic imbalance in the diagnosis of preeclampsia. The Parrot trial, the Inspire trial from Oxford, led from Oxford, using the ratio, have shown the same. Both these tests have been incorporated into NICE guidance and saying, basically, if you have abnormal, treat them more seriously as if you have preeclampsia. If the test is normal, you can be more reassured that you don't have to get worried. Now, there are lots of tests out there. These are the big ones in the UK, for example, and we know that they are relatively expensive. You have to pay £50, sometimes £100 when you start including the prepping agents. They have to be sent off to the lab. You have to spin the blood to get plasma and serum, and you may get a result back in a day or two. So there is expense, there is time, and a lot of the benefit of a quick answer is lost. One of them, the triage test from Quidel, actually is a bit more point of care, but it's not really point of care because you still have to spin the blood. You can't do it on whole blood, and it's still relatively expensive. So there is an alternative, and this is very exciting. So some of the companies who make the big analyzers are also developing other analyzers. The middle one there, the Ronia test, and the one on the right, the Lepsi test, are both whole blood tests, and they can be done on the bedside. Both companies that make that, Revity and Lepsi, are committed to marketing these at a lower cost, and potentially at a very effective cost for using even in low-income settings. So there's no laboratory requirement. You have incredibly fast turnaround times, possibly finger prick, even minutes. The women are kind of there getting the test done, are engaged with it, and certainly is potentially a runner in a low and middle income setting. So I'm going to share with you some of the results from our various programs of work, and they are very exciting. So this has been published recently, which is basically looking at these new point of care tests to rule in and rule out preeclampsia. And what I can tell you is they're just as good as the big expensive analyzers. So when we've compared them and come up with the relative cuts, they are reliably telling us that you're not going to get preeclampsia in a couple of weeks. And if you do have an abnormal test, you've got a pretty high chance of having a problem. I do want to show you this data though, which is hot off the press, as it were, being considered for publication. I think this is from our teams. Katie Curtis led on this, and all the wonderful teams in Sierra Leone. You can see that in a data set, the first thing to say is in about 500 women, over 100 of them, so more than 20% of those women are actually, babies are actually dying. So we have a mortality rate, and baby mortality rate, of over 20% in women who come in with hypertension, which is a phenomenal lesson in itself. Of these 500, less than 500 women, 62 had a really serious event. And what I mean by that is they either died or they had an eclamptic fit. But if you look at these bar chart, let me take it through you. It's very important. On the right, there is no red in that bar chart. And what that means is if your PLGF is normal on this Lepsi device, there wasn't a single woman who died or had an eclamptic fit, and not a single baby that died. Conversely, if it was abnormal, very low, 50% of those babies died, and more than 20% were having a severe maternal event. So we have an incredibly good triage test in the context of one of the most challenging environments in the world to make a difference. We are now taking this test, and with our colleagues around the world, doing Papagaio, which is the parrot in Portuguese, because I'm working with Leandro Oliveira, and his teams in Brazil, but also with our old teams in India, as well as phenomenal teams in Sierra Leone, Zambia, and South Africa, to actually look at these point of care tests in managing the problem, including early assessment, but also before 34 weeks and after 34 weeks in determining who you should deliver. So I think a very exciting program of work. The papers are being published now. They are definitely very good tests. Why do we need to know this? Because large parts of the world are very challenged in terms of triage. We know that getting a woman to the place where she can be looked after and potentially delivered in a timely manner is a huge lifesaver. And many women are far from any facility that can actually offer that care. And there has been great effort by many organizations in providing ambulance service and all sorts of other things. And the reality is that's not always sustainable. This is from our teams in some of the distant districts in Sierra Leone. A woman, if she is in trouble, has to get on motorbikes, get on boats. It is very challenging. And to have a simple test like the cradle device and then triage with something like a finger prick test or a simple blood test is going to make all the difference in terms of actually delivering her in a timely manner and saving lives. And again, this is the sort of action people have to go through to get a woman there. I'm going to finish now just by saying a phenomenal number of people have been involved in getting this work together, both in Zambia and Sierra Leone particularly. It's a huge effort by a diverse team with all sorts of skills. It's not just the clinicians, but the people who make things happen in the background, who help us with the governance, the travel. What a phenomenal team. I'm going to go back to what Lucy was saying. It's about legacy and building. These teams are going to carry on working for the next decades, long after I retired, I hope. And I think we are making a difference. The great thing about pre-eclampsia, if there is a great thing, is it's a terrible problem that has a relatively simple solution if we just grasp the nettle. So on World Pre-eclampsia Day, I think we have at last got a test we can actually use that could make a massive difference to these outcomes. And I'm really excited to kind of be in this space at this time. I'm going to be a little bit naughty and use this platform to advertise something. I always say to my team, if you have an opportunity, don't just moan about it, do something about it. A lot of our team are very interested in acute kidney injury, of which pre-eclampsia is a major cause. And I'm just going to ask you, if you can you go onto this QR code and spend time filling out this questionnaire? We're trying to work out how to prevent acute kidney injury, which also is involved in pre-eclampsia management. Hopefully I'll persuade Marcus to stick it in the chat so people can access it later as well. We've got time for some questions. And again, I wanted to thank everyone for spending the time coming to listen, and please do stay. We've got a very exciting next hour with a huge diverse group of people with immense experience from around the world. Jimmy, over to you if there's any questions.
Thank you very much, Andy. That's a very impressive overview of the subject and also the specific subject of PLGF. And what's interesting, if your last picture of your team, it's always important to remember the number of people behind the speaker who have done not all the work necessarily, but a lot of the work in actually getting the work together. And they're the ones that are going to move on and do work in the future, as Andy and Lucy have implied. Now, there are no questions at the moment in the Q&A part, please, and so please feel free to do that. There was one question in the chat, which you really sort of answered, but I'll sort of ask it anyway, and that is that it's asking whether you had any preference of the different tests for either PLGF in its own or the ratios, and you implied no, but of course this new point of care test might be a step forward. So, do you want to comment on that?
Yeah, no, I mean there are some more comments to make about that, Jimmy, and thank you, because I can actually expand a little bit. So basically, soluble FLIT, when PLGF becomes undetectable, it's just very low, and you know things are bad. Soluble FLIT will continue to rise. Therefore, there are some people who believe that you might continue to be able to triage the severity of the disease by looking at soluble FLIT, and the jury's out on that. We don't know whether you can track severity yet. However, the Gates Foundation and others are very interested in therapeutic measures here. So one of the things that's been looked at is suppressing soluble FLIT with various therapeutic interventions, including messenger RNA technology. Now, if you're going to do that, you do need a measure of soluble FLIT to titrate the drug. So although this is kind of, future stuff and we're a way off yet, there may be some merit and need to do soluble FLIT measures for that purpose. However, today, if we just want to know, is the woman sick and do we need to deliver her, PLGF will tell you just as much as the soluble FLIT, and we do know that the PLGF ratio, tests from the various companies is just as good as the ratio test from the various companies. So there are other reasons that we decide which test to use. One of them is, can we get a cheap whole blood test? And there are technical reasons why PLGF is much simpler on a point of care test than soluble FLIT, although we are working with others to try and develop point of care tests for soluble FLIT. And they, you know, we have to watch this space. So things like, what does it cost? Can you do it quickly? Can you do it easily? So the aim is to keep it cheap, do a finger prick, get a result in minutes, have it by the bedside, and we're getting there. I think all the companies are working hard to try and provide that. And I think the cost is going to be the big thing for most of us around the world, I think, if we're going to make a difference to the people who need it most. But it is a nice move improvement in getting a really good test, you know, better than all the other things we used to do, and cost money, liver function, whatever. And I'm very excited about this. I think within months rather than years, I think this is going to become a reality.
Thank you. One of the first questions in the Q&A is from KV Malini, who's asking, at what period gestation do you recommend testing for PLGF?
Yeah, so I mean, the first thing to say is later on, it doesn't add much, because we know that if you have preeclampsia from 37 weeks, the default is to measure. And increasingly, we think that even delivering a bit early is a good idea. So you don't really need to do a test if you know you're going to deliver that woman. And actually, paradoxically, the test doesn't quite perform so well beyond 37 and maybe even beyond 35 weeks. So fortunately, the test works best before 35 weeks and maybe after 20 weeks when you want it the most. So those are the women where the baby may be able to survive. You have that delicate balance of when should you deliver it for maternal benefit, but not to harm the baby with immaturity. So the test seems to be most valuable in that point of care suspected preeclampsia cohort, those women who turn up, who've got high blood pressure, headaches, other symptoms, small baby, and you're just not sure if this is genuinely going to turn into a horrible outcome or not. That said, there are some people can use the first trimester test to actually say, yes, you're going to get preeclampsia much later. They can then target things like low-dose aspirin. So there is going to be work. And I think these point-of-care tests are also going to be good enough to be able to measure the low levels required for first trimester screening. And some of our teams are kind of working on that as well. So the quick answer is, you know, that 24 to 35 week window is when it's most beneficial. Beyond and below that is still open for interpretation.
Thank you. The next question is from Ellie Watson, who is asking that they have particular problems in diabetic women and in deciding whether proteinuria is important because of obviously it could be the diabetes rather than preeclampsia. Is the PLGF or soluble FLIT ratio reliable in that setting as well? Yes, they are. And I can always rely on my previous PhD students to ask awkward questions. Ellie's one of those. So yes, I mean, the obstetric medicine and the physicians who are really delighted that we actually have a test that tells you in those challenging cases where you have underlying blood pressure trouble, you have proteinuria for other reasons. And, you know, you really struggle because they can be severely hypertensive or they can be churning out protein, and you genuinely don't know if that is a response to the preeclamptic process or that's a sign of an underlying medical condition. And we have plenty of anecdotes and more to say that the test is incredibly reliable in that group. So you can say, look, if the PLGF is normal, you know it's not the preeclampsia driving the pathology. It doesn't mean that woman's normal, because she still can have problems from the presenting condition and her diabetes, but it does mean that she's not going to have a crisis in the next few days from preeclampsia, and, you know, unlikely to have a abruption, unlikely to have a stillbirth for preeclamptic reasons, and that really helps the management. So actually, more than paradoxically, that subgroup of hypertensive proteinuric women or other features of preeclampsia, it's particularly useful, has great clinical utility. So just on that subject, Dr. Mandaba is suggesting that diabetes actually affects PLGF levels. So, so are the range is still valid, the same range as 12 as a cutoff point, for instance?
Yeah, I mean, there are lots of things that affect levels. We're looking at this. So, you know, everything from ethnicity and so on. The bottom line, and twins, you know, we just don't know. They do affect the levels, but at the end of the day, if they are very low and undetectable, that is usually significant. I think the literature is going to evolve and expand as we use these tests more, and we'll probably start getting subtle kind of changes in our pathways as we realize people are different in subgroups. But the bottom line is these subgroups will still have a benefit from these tests. In the same way as we sort of change our clinical algorithms for cervical length or whatever, depending on different subgroups, we'll probably change our management in the future. But the research is being done, and I think they're going to be reliable.
So slightly on a similar subject is that Tracy Nelson comments that in their pregnancy assessment unit, they have fluctuating levels of PLGF when they measure women in a serial way, from say from mid-range and then to normal. And is that a common thing? You find that they can fluctuate from a sort of one band into another band?
Yes, so I mean, Alice Hurrell has done her entire PhD on this exact point, doing sequential readings and looking at the need for repeat testing. And that Lancet paper that came out in the last year categorically tells us there's no need to keep repeating it. There are small numbers who change categories. For the vast majority, it is either very normal or it's completely undetectable and you can characterize accurately. There is a subgroup that is intermediate. The conclusion from that study is repeating the test doesn't really change outcomes. So for most women, you do not have to repeat every week or whatever. There's a subgroup who will continue to be pregnant, say for a month or so, and may then represent with worrying features. And I suspect you have to have discretion. And if you do the test in that group, there will be added value. But we now know there's no need to routinely repeat, because the vast majority of people will be characterized accurately on the first test, and we know that repeating does not improve outcomes. Routinely, anyway. Yeah.
Again, and I think you've covered this to some extent before, and that is it a useful test for differentiating chronic hypertension and with superimposed preeclampsia? So
yes.
Would you follow someone with chronic hypertension, particularly to see whether they may develop preeclampsia?
Yes, I mean, there are differences in these women because, you know, aspirin benefit and stuff like this may be different in these subgroups, but at the end of the day, the test itself is very reliable in the same way as the diabetics and other kind of renal disease and so on can be discriminated. The chronic hypertensive who's, you know, becoming awkward because you don't know whether the growth restriction or the proteinuria or the symptoms are superimposed preeclampsia, this seems to be a great use of the test.
So another question is two questions really I put together, and that is that someone's commenting on the fact that even though it's in the guidelines, even though APEC have been pushing it very, very hard, is it's not utilised in every hospital, and particularly in DGHs down the road from teaching hospitals, because of potentially of the cost and other barriers. So what barriers do you see that stops people using it? And is this new point of care test, will that actually open up the possibility that these hospitals who may have a slight less need of it on a regular basis to actually utilise it?
I mean, there's an out of sight, out of mind problem here. People don't know what they're missing. And I guess it comes down to local budgets and people having to pay for it. So even though it's recommended and there is money out there for it, it hasn't always happened. What's great is NHS England, as it was, has been able to kind of roll this out, and a large majority of hospitals have access to it. And through the work, you know, Mark is sitting next to me here, been badgering the Scottish government, and that looking better all the time. And so it is an uphill battle. In answer to your question, absolutely. You know, having laboratories having to take on these analyzers, the costs is not, you know, although it's cost saving overall, the reality is someone has to fork out and buy these things and make it happen. If we end up having a point of care test that is a lot cheaper, there's no doubt that that's going to ease the way for using it. I think if it comes under the control of the clinicians, you know, with the right governance blessings from their hospitals, I think people will kind of vote with their feet. Yes, this is a test I can have in my clinic and I can benefit the women I look after immediately, rather than going through all the headaches of a laboratory-based test. So I'm sure costs and ease of access is going to help in the UK setting, as well as this sort of exciting work for the global health.
So just to finish off, Andy, one of the things, as you know, is that is one benefit actually getting a diagnosis or potential diagnosis or risk categorization is what to do next. And you know, if we're going to improve the figures, then you've got to get the management right. You know, how about the development of guidelines which are suited to the local environment? Is that something that APEC should be more involved with, and you're involved with in helping people know what to do with the results when they get them?
Well, exactly. I mean, I think the nice guidance has put the you know, tests into that algorithm of when to upgrade or downgrade your actions, and you fall into the recommended action, so you can just read them. You know, you're now green, therefore you're in this category. You're now red, you're therefore in this category. One of the work we're doing at the moment, and you know, we're going around the world getting advice from our colleagues in South America and India and Africa about, you know, how will you use this test? And I think the bottom line is, if you have an undetectable level and you're red and you've come in with hypertension, we are telling people, treat this as preeclampsia. We're not saying deliver, we're saying treat this as preeclampsia. And conversely, if it's normal, we can say this is incredibly unlikely to be preeclampsia. You can act accordingly. So part of the trials is actually working through the actual pathways and the advice we're going to give people. If we can prove that it's safe to reliably say, you know, treat this as preeclampsia and not treat this as preeclampsia, and we improve outcomes, then we can recommend those pathways. So it's an evolving area. I think, as you say, it has to be locally interpreted, and a lot of our work is actually looking at both community engagement and other engagement with our colleagues around the world to say, how would you use this in your environment? And make sure we're not causing a problem by, you know, reacting too quickly, but equally we want to prevent those stillbirths. So an exciting area. I think there's a lot of research that's going to come out in the next few years, and I think, in answer to your question, this will evolve, but there's no doubt in my mind it's a very good test. The question is, what's the best way to use it, and we will learn.
Okay, well, thank you very much, Andy. I hope everyone agrees with me that that's a very, very exciting sort of presentation with a lot of future involvement. And I thank everyone who's put a question into the question and answer session. I'm sorry I didn't manage to cover all the questions that were put up. I want to move on to the next presentation, and this gives us a wider sort of look at the effect of preeclampsia and the environment that it's within. And this is a recording from Dr. Nadine Fontaine-Palmer, who is someone who is an expert in culturally sensitive research and community engagement, and she's going to talk about the sort of a wider range of things relating to democratizing health research and the personal story of a professional paradox. So this is again a recording, and I hand over to Nadine to tell you all about it.
Hi everyone, I'm Nadine Fontaine-Palmer and I lead APEC-UK CIC. Today I want to talk about valued lived experience as a source of expertise in health research and our mission to democratise health research, leveraging the power of the voluntary and community sector. I'd like to begin with something pregnant again in 2024, I expected to be at even higher risk. The doctors told me that this time the assessment tool, the clinical algorithm, scored me as low risk. And when I asked how they could be so sure, they explained that the tools were based on incredibly sophisticated and robust research. I asked to take aspirin anyway as a precaution, and they said no. Now here's the paradox. I believe in research. I'm the CEO of a non-profit focused on community-based research that amplifies marginalised voices. I hold a PhD funded by the Medical Research Council, and my work now includes designing hypertension screening interventions, and yet none of that reassured me. My body and my instincts were telling a different story. As a Black woman in the UK, I was acutely aware that we are more likely to die during pregnancy and childbirth than white women. And these aren't just statistics, they represent a terrifying reality that shaped how I approached my care with caution and hypervigilance. One doctor kindly offered to send me some academic papers to support the assessment, but I could not read those. Despite my professional commitment to patient advocacy and self-education, in that vulnerable state, when overwhelmed with fear about my pregnancy, I found myself unable to access the very skills I use daily in my work. I just did as I was told. The rule follower in me took over. 5 days after giving birth, I was diagnosed with pre-eclampsia. Now, some doctors explain that I might have developed postpartum pre-eclampsia, a condition that emerges after birth. However, some doctors said that based on my medical notes, it was likely that pre-eclampsia was missed during my pregnancy. And the truth is, I'll never know. But I do feel anger at the potential risk that both myself and my baby would have been exposed to if indeed I did have pre-eclampsia during pregnancy and I developed any complications. More than anything, I felt angry at myself that by relying on the research and ignoring my intuition, I may have put us in danger. And I spent much of my daughter's first month in and out of hospital, separated from her in a time that I'll never get back. I do believe in research as a force for good, but my hypervigilance as a Black woman, aware of maternal health inequalities and the fear of pregnancy after loss, suspended my normal researcher mind. This wasn't about knowledge or awareness, which is often the target of public health campaigns. This was about a complex interplay of professional experience, identity, and racialized trauma. And all of this reminded me that research and data are not enough, especially when it's presented without context, without space for lived experience. Sometimes your gut knows what the research might miss. And that gap between clinical confidence and personal reality is where many people live, especially those from marginalized communities who have seen systems fail them. That's why we must make space for stories and lived experience, not as a challenge to science and the methods we learn through our academic training, but as an essential part of it. By positioning communities as co-creators rather than subjects, we can expose critical gaps in clinical algorithms and create research that is both scientifically sound and culturally relevant. And this is exactly what we do at Mappadilico CIC. We are a Black-led community interest company, and we centre lived experience in health research, service design, and system reform. We combine deep community engagement with behavioural science and social science, working with health systems and funders to try to amplify the voices of the seldom listened to and create equitable partnerships with communities, not extractive ones. Across our co-design projects, we've heard hundreds of stories that explore health behaviours and engagement in health services. And like mine, they are often featuring misdiagnoses, miscommunications, stigma, and the emotional toll of not being believed. From hypertension to diabetes to mental health, the themes they repeat. People describe feeling dismissed, racialized, blamed, or siloed into treatments and medicalized solutions that don't reflect their cultural or socioeconomic contexts. We hear these things when we speak about engagement in health research also. They want to trust, but as a result of personal and sometimes group trauma, they are vigilant, hyper-vigilant. But they also tell us what helps: community-led spaces, peer validation, and being heard without judgment. These insights don't emerge from clinical trials. and they don't always emerge from qualitative studies led by formal research institutions like universities. They come from deep listening and listening by the right people, and they are essential to building responsive, effective, and culturally grounded interventions. Too often, health research treats communities as data sources, not knowledge holders. We see shallow engagement, advisory boards that hold no real power, research questions already set, and rigid systems that can't flex to cultural or contextual truths. We are involved in a thing that has already been decided. So people, especially those most at risk, get left out of shaping the very research meant to serve them. We need to flip this model and drive structural shifts in power that democratize knowledge and the relative value we put on its different forms. We have the privilege of speaking to health professionals and researchers, and many tell us with great courage, but actually they find all of this really hard. Funding, of course, is a big part of the challenge, but actually many find it challenging at a deeply personal level, finding it hard to understand how a community perspective might be considered as valued as theirs. We have heard researchers challenge whether bias or racism truly exists in their institutions or work, with some displaying acute defensiveness, even in 2025. So this journey requires some cultural humility, some self-reflective honesty about why the status quo persists, and it needs leaders that are willing to go there. However, many absolutely embrace this mission and what we hope to achieve. And we strongly believe the voluntary and community sector organisations like ours can help, but not just as recruitment partners. Some of us are researchers based in the community. We are cultural translators and we are trust holders. And when we are treated as equal partners, communities don't just influence uptake, but they can influence research design, priority setting, and outcomes. I spend my days promoting health research, and I still believe in its power. I also believe in our health service, and I'm so grateful for all of the midwives and doctors and administrative staff who helped me meet my baby. I'm also grateful to my colleagues turned friends at King's College London and King's Health Partners who took urgent calls from me seeking second opinion on my pre-eclampsia treatment plans. But my experience has taught me now from a very personal lens that when research is disconnected from lived reality, it stops being reassuring and it can become alienating. Democratizing research isn't just about inclusion, it's about making it work for the people it's meant to serve. If we want systems that work for everyone, they must be built by everyone. And that starts with listening, really listening to the stories, the instincts, and the wisdoms communities already hold. Thank you to the organisers for inviting me to speak and letting me do this pre-recorded presentation while I navigate the challenges of being a CEO on maternity leave. It's really great to do this during that time with my 5-month-old, very beautiful, very healthy girl sleeping next to me. And thank you to you all for holding space for this story and this message. And if anyone is interested in reading more about my story or our mission, partnering with us to listen to communities, or finding out about our programmes to build capacity for equitable research in both researchers and communities, then we would love to hear from you. Thank you so much. Hi everyone, I'm Nadine Fontaine-Palmer and I lead APEC-UK.
Well, so I want to just say thank you so much. Oh, just mute. Thank you so much, Nadine. That was incredibly powerful and actually deeply honest reflection of what you've been through. You really remind us that transforming maternal health isn't just about the clinical, it's not about the academics, it's relational. It means listening to the voices that are often excluded, addressing power imbalances, creating those systems that really honour both the evidence and the lived experience. So we're moving into our next segment. So we're going to be zooming into prediction and prevention of preeclampsia. So we're going to keep those values central to us still: equality, equity, inclusion, and responsiveness to context. So we have two amazing experts, one from Brazil and the UK as well. And we really want to kind of ask those difficult questions. Who needs screening? How can we do it? How can we prevent preeclampsia based on that risk? And actually, there are so many places that don't have solid screening infrastructure. The global majority, let's be honest, what does prevention look like for those people? So really delighted to be joined by Professor Leandro de Oliveira and Professor Jenny Myers, phenomenal experts, and I'm sure you know them well, both clinical researchers, leads of our Papagayo study, PREPARE study in Brazil, and of course, Jenny Myers from Manchester leading the Starship trial amongst many, many others. So I'm going to kick off, and I want to ask you guys to keep to time and respond to this in one sentence, which is basically impossible. But anyway, Leandro, I'm going to start with you. What is the single biggest change we need to see in how the world approaches preeclampsia prediction and prevention?
Well, thank you very much for inviting me for this marvelous event.
Leandro,
Muted. Oh, sorry. So, well, I think just in one sentence, right? Well, I think I think what we have to have in mind is that it is quite important for now to stop trying to propose a single method to predict and a single approach to prevent preeclampsia across the world. There are lots of disparities to be considered for this point. This is my sentence, I could say.
Amazing. Thank you. Thank you, Leandro. Jenny, I'm going to pass over to you as well. What do you think in your response?
Yeah, thanks. Thanks, Alex. I think opportunistic, I think, would be my word. Put that into a sentence. So, as Leandro says, there are many different ways of screening for preeclampsia, and as academics, we can spend, and we will spend, I suspect, over the next few decades, lots of time and energy kind of comparing one test with another in environments where we're lucky enough to have the opportunity for more sophisticated algorithms. But there are actually a lot of things you can do at minimal cost, and being opportunistic whenever you encounter a pregnant woman, and thinking whether there is something you could do that would intervene in her risk, whether that's early pregnancy screening or later pregnancy identification. So be opportunistic, I think.
Yeah, amazing. Thank you. I love them. I love them both. Leandro, over to you again. So I think, as we've already slightly alluded to, a key challenge in low resource settings, and you've said as well, Jenny, is about just reaching the woman in front of you. And I guess early is also a really, really important point to kind of bring home. In your work so far, who most needs screening, and how do we use innovation? How do we use kind of different strategies to actually reach those women, even in settings where, you have limited ultrasound, you have late antenatal entry?
Yes. Well, I think I can go to the point that different populations must be seen in different ways again, and consider again the disparities and inequalities we have across the world, and especially to my center, especially to Brazil. We have a huge country, and we have lots of disparities across the country. You cannot consider women, for example, in the center of the city of São Paulo, and you cannot compare this population to the northeast of Brazil or from the north of Brazil, where we have the most vulnerable population, I could say. And another point in Brazil is that we have two different healthcare systems. The vast majority of the women, 75% of the women at reproductive age in Brazil use a public health care system, and only 25% rely on healthcare insurance, for example. And when we talk about this population, these women represent not more than 40 million women. It's quite impossible to take care of these women properly in an equal way. It's quite problematic to try to do this. And these women in the public health system, they start the first antenatal care visit at 13 weeks of gestational age. So it's quite late to do some first trimester screening, for example. So it's quite complex. The other population who use the healthcare insurance, they start earlier, and they can have they can even do the screening at first trimester, for example. So I think what I could say is that this special group, this special 75% of women in Brazil needs to be screened, and these women should receive the screening. But again, it's quite difficult to use this screening in this condition, because in the health system we don't have very much money to do this screening. So this
Leandro,
is the focus.
You say 13 weeks, but I'm very jealous. Our average age of presentation in Sierra Leone is 22 weeks.
Yes, I know.
It's a huge challenge, and I hear what you're saying. And it takes a big mind shift, and really engaging with women and allowing them to understand and to really speak the same language in terms of why it's important to come and get screened. So Jenny, Starship is a very exciting project. You are pushing the boundaries on how we screen. You want to integrate the exciting biomarkers like we've heard Andy talk about in terms of PLGF into routine NHS care. Can you just talk us through your approach, implications for health equity, I guess some challenges as well?
Yeah, so the Starship study is a UK funded study where we're going to try and implement the I guess you might call the most sophisticated method we have available at the moment for screening for preeclampsia, and it's a multimodal test designed by the Fetal Medicine Foundation, and it includes taking a history from the woman, measuring her blood pressure, performing uterine artery Dopplers, and measuring placental growth factor, and you put all of those into an algorithm and it will come out with a risk. It needs to be done between 11 and 14 weeks. So in the UK, most hospitals will use risk factor based assessment of a woman's risk and prescribe aspirin based on that risk. And if you compare a risk factor approach compared to the FMF algorithm, the detection rate for women who are going to be affected by early preeclampsia, so preeclampsia needing birth before 37 weeks, the detection rate's approximately doubled. So in the UK, where, as I said, we've got the luxury of a organised healthcare system where about 90% of our women will access pregnancy care by around 14 weeks, we've got a really great opportunity to look at how we can implement that test. But we've really got to do that responsibly, and we've got to work out whether that is cost effective. Who does it benefit? Are there any hidden consequences? And if you spend public healthcare money, it doesn't matter which country you're at, if you spend that public money on one aspect of healthcare, you're going to take that money away from another aspect of healthcare. So we've really got to think carefully about how we spend our money wisely, and determine which components of that sophisticated algorithm are really the things that really make the difference. And the really exciting thing I think about being able to do it at scale is that we can look at the individual components and work out which of those are translatable to other healthcare settings. So is uterine artery Doppler really giving added value? For example, is placental growth factor testing actually better than taking a history or measuring blood pressure? Is measuring blood pressure actually the thing that makes the difference? So let's really get at those components so that we can scale up that approach internationally.
So Jenny, I'm assuming you're not about to reveal to everybody that one thing we need to do. Presumably not. So screening is just not, I guess, the end point, though. It's the gateway to prevention. I think as we're getting more sophisticated, we're trying to think about personalizing aspirin strategies, especially in high income settings. Is there any way to kind of help us to make sure that aspirin is more effective or kind of equitably delivered? And I know in our hospital in St Thomas's, there is this real problem where not everybody who needs it is getting aspirin. So any top tips from you?
So again, it comes down to being opportunistic and doing the risk assessment and making sure that if you have the opportunity to see a woman, do a risk assessment, even if that is measuring blood pressure and taking a history, which is miles better than not any risk assessment at all, then you've got the opportunity to offer aspirin. We keep it simple. We give everybody 150 milligrams. We could talk for a couple of days on whether that's the right approach or not, but that's the message we give. There's no point just giving women a prescription for aspirin, though. There are many other barriers, and women need to feel confident, and they need to understand why we've asked them and why we've recommended that, and we need to talk to them about the risks and benefits. And I think that's something that as doctors and midwives we must understand much more responsibly. Just giving a woman a prescription of anything, antihypertensive, aspirin, that's only part of the conversation. Women need to understand why we've asked them or why we've recommended, why we're offering that intervention. And so again, be opportunistic, screen, and if there's an opportunity to offer a woman aspirin, it's very unlikely to do her any harm, very unlikely, if she's got some risk factors for developing preeclampsia.
Amazing, which actually kind of brings me quite nicely into my final question here, which is, I guess, we've already talked about how screening is very tricky in a low resource setting. Why not just give it to everyone? Should we do universal aspirin, Leandro? Are there risks, or should we just go for it? Either over to you, Leandro.
Yes. This is a tricky question, really, especially in front of Jenny now. Well, I think in my clinical practice, what I could say is that I've seen that some group of women, they present so many risk factors in the same patient, the same woman, that I really sometimes would like to implement this universal use, right? Really, just because it is just a matter of opportunity. If I start using an universal aspirin recommendation, for example, and if I could reassess this risk later, for example, at second trimester, for example, and I could rethink about this use, it could work for some groups. For example, if I go to the northeast of Brazil in some rural areas with very difficult access to service, it could work. We start with aspirin and reassess when we have opportunity. So again, I think we need to discuss these different populations, and we need to discuss these different moments and different kind of women. I think it's not a very weird idea to use universally in some groups. This is my point of view.
Jenny, any feedback, or otherwise we will
I think it's about understanding your population and assessing benefits and risks in each setting, and there is absolutely no one size fits all, and the risk balance ratio is going to be very different in different settings. I think in a UK population certainly, and in European populations, probably universal aspirin probably wouldn't be as effective because a lot of women wouldn't take it, and B, we would have a lot of women on aspirin who didn't need to be, and as you scale that up in our healthcare settings, the harm would probably potentially outweigh the benefit, not probably. So I think in other healthcare settings, as you say, Leandro, that may well not be the case, and I think that's where we've got to think about being flexible and agile about these different strategies. depending on that risk benefit ratio, depending on how quickly you can present, where is your access to the next step, all of those issues.
Yeah, absolutely. Flexible, agile, and opportunistic. I like those as takeaways. And equitable, I think, is also really important. Thank you so much, both of you. I think that we are now moving on to our next speaker. So we know that once we've predicted and we've tried to prevent, we're not unfortunately at the end of the road. And one of the most critical and often complex decisions in managing women with preeclampsia is about when to deliver. You know, that balance. And so I'm very pleased to hand over to Alice Beardmore-Gray. She will be chairing our 5th lecture, clinical lecture at King's Health Partners, King's College London, and a very global panel that will be joining her. Thank you so much.
Thank you, Alex, and thank you everyone for tuning in. It's amazing to have so many people here. And as you said, we're now kind of moving on to think about, once you've diagnosed preeclampsia, what do you do about it and how can we optimize management? And we heard earlier from Andy about some of the diagnostic challenges involved, and the potential for PLGF-based testing to help confirm the diagnosis of preeclampsia before delivery. So what we hope to illustrate in this session is that critical conversation between a woman and her care provider, and really emphasize the need for a shared decision-making process that keeps the woman and her values and beliefs at the core of it. And we've heard from Lucy and Nadine how important this is, and just now from Jenny as well, the importance of discussing risks and benefits properly. So to illustrate the common and often hard decision, I'd like to introduce you to 2 of the Cradle 4 trial team members who are representing an amazing team from across India and Zambia. And this team delivered the Cradle 4 trial, which, as you've heard, was a large RCT, which aimed to find out whether planned early birth for women with preeclampsia from 34 weeks could improve outcomes for mum and baby. And we found that early birth did reduce the risk of severely high blood pressure for the mum, and importantly, the risk of stillbirth by 75%. So we're now again thinking about implementation and about actually getting that intervention to where it's needed. And so working with a wider team, including Dr. Katie Kurt, who you'll hear from later, on developing some tools to help facilitate that discussion and decision-making process, so that women have access to the most up-to-date information available, and so that they can make the decision that feels right for them. These are still in development, but we'd love to hear from anyone that's interested in providing feedback on them. We did have a slide illustrating one of them, which I'm hoping may appear as I'm speaking, but if not, we'll circulate it at the end. And I'd like to hand over now to Sister Josephine Mitti, one of our brilliant research midwives from Lusaka, and Professor Gitanjali Katagiri, one of our fantastic collaborators from Bagalkot, India, who are going to demonstrate some of the tricky questions that come up and how they might be discussed in practice. And I think this is so important because, as we've heard, you can have the best intervention in the world, but if you don't bring it to the communities that need it and implement it effectively by engaging people in these conversations, it's meaningless. There we go. So I'll leave that up just for a few moments and we can show it at the end, because we're now going to move on to their pre-recorded conversation. It's pre-recorded because Josephine is currently appearing on national television in Zambia as part of their local campaign to raise awareness of World Pre-eclampsia Day. So if we can hopefully play the video. Hearing any sound.
Hello, Madam Josephine.
Hello, Doctor.
Yeah, you look a little worried. What's the problem?
I came for my accidental visit, and when they checked the BP, they found that my BP is high
and had high levels of protein in urine. Oh, okay. So then let me just examine you once again. Let me check your blood pressure again. Okay. So yes, so we have done your blood pressure recording twice now. At both times, I'm finding that it is high and it corresponds to what has been found before. And also we see that there is a significant amount of protein in your urine. Considering all this, I think it's best that you... Well, come again? Considering all the findings, that is you have high blood pressure and you have significant amount of protein in your urine, I think it's best that you admit it. But do you think it's necessary? Why don't you just give me medication? Okay, I think I should explain the situation to you so that you understand what's exactly happening. So when you have this high blood pressure and you have protein in the urine, we call it as a condition called as pre-eclampsia. And the reason why I'm asking you to get admitted is because this can usually cause some complications in the mother and in the baby also. And this is because it can affect the functioning of many of your organs. So you might feel fine now, but it could be that there is something going on inside, which we will get to know only when we do further blood tests or some other investigations. So to evaluate all that, I think you better get admitted, and then we could discuss the further line of management beyond that. I think I also need to tell you another thing, and that is that because I already told you that it is affecting organs in the mother. So the only reason why we would continue the pregnancy is if the baby was very, very early in the pregnancy. That means it's not mature enough. But if the mother is severely affected, if the blood tests or the other problems that she's having are significant enough, then we would advise delivery because it is better for the mother, safer for the mother. And so delivery is the only treatment for preeclampsia. So you would need to consider this also. Of course, we will be able to speak further when we get your test results. So you would ultimately need to be delivered soon. But do you think my baby is going to be fine? Yeah, that's also a very important aspect of the care for you. So as I said, the reason for pulling on a pregnancy, even when there's affectation with preeclampsia, would be for the sake for the baby to get a little more mature so that it has better chances of doing well even after delivery. So if you were very early in your pregnancy, like let's say if you were well within 8 months of pregnancy, then the baby would need some more time to become mature enough to survive. And if there were no serious mother's concerns, no abnormal blood tests or the blood pressure is under control, then in that case, we would usually wait that the baby becomes more mature. While on the other hand, if you were like well advanced in pregnancy and we're very close to your due date, then because the baby is already mature, we would definitely consider delivering you because otherwise it would lead to more complications in the mother and in the baby also. In your case, I can see from your records that you have completed 8 months of pregnancy yesterday. So if all your blood tests, of course, we would be able to speak only after your blood reports and your other tests that we have sent all come back. And if you are reassured that your reports are fine, then we have 2 ways of approaching. So one of them is that we wait and we keep monitoring you. And if you develop more serious worsening of the condition, like your tests become abnormal or your blood pressure becomes uncontrolled, or if you find any other signs of either the baby not doing well or you not doing well, then that could be the time at which we decide to deliver. But the other option that we have at this time is that we go for a planned delivery. That means at this time, when you are not very seriously affected or your baby is also doing well, because it is a pregnancy which has crossed 8 months, the baby is reasonably mature and we have good hopes that the baby is going to do well even after delivery at this point. It is quite capable of survival independently. It may not require too much of support after delivery. And perhaps delivering the mother at this time gets even better results in terms of a less sick mother and also a baby which is going to do well. So in fact, we have had evidence from hospitals like the one we are in right now in low and middle income countries, which is showing us this kind of reassuring result. And so I would be quite comfortable delivering you at this time. So yes, to answer your question simply, I think your baby will do well even if you do deliver now.
Anyway, you've explained well, and I've understood that there are less risks for me and the baby. Yeah. But I don't know what my husband is going to say, if Pato is going to be agreeable to the delivery, especially that you want to deliver me before 9 months. So give me a bit of time so that I can discuss with him, and then I'll get back to you.
Yes, I'm happy that you understood the seriousness of the situation. And of course, involving your husband in this decision-making process is very, very important. So yes, please do contact him. Maybe he comes down here and we could all discuss together.
So I've spoken to him on the phone because he apparently is at work. And then he'll pass through in the evening. I've explained to sir that you've admitted me and that I need to be delivered egg. He's also agreeable.
That's good.
Because at the end of the day, what we want is a healthy baby and a healthy mother. Yes.
Correct.
So I think you can go ahead and deliver me. But
yes.
we are just worried of mode of delivery.
Yes. So again, I will wait for all your reports to come back to confirm everything that we've just spoken. And regarding the mode of delivery, so even if you are not in labor, even if you're not experiencing any pains right now, we could induce artificially the labor pains with some medications. And there is a good hope of having a vaginal delivery. Only in case if there is no progress, or if you find that the fetus or the baby or you are not doing well during labor, then there is also a chance for cesarean section, but it need not be an outright decision for a cesarean section. You could very well deliver vaginally also. Hello, Madam Josephine.
So I think,
yeah, you look a little worried.
So I think that hopefully gives you a flavour of the type of conversations that hopefully armed with information you can go and be having in your own practice. I'm going to leave the closing remarks to Dr. Bellad, who is another one of the Cradle 4 investigators, and then I'll introduce the next session. So Dr. Bellad, please, could you summarise our key messages?
Yeah, good evening. Thank you for the opportunity. And I think there was a wonderful video recording of how the doctor and the pregnant woman with pre-eclampsia conversation goes on. It's actually in LMIC, this is really challenging because important aspect of that is education. See, once we explain there is an understandable patient. Invariably in developing world, these women, they say that we have not come prepared for admission, so we'll go back and come. And there it's very important that we should be counseling them what are the important aspects. And this being a late pre-eclampsia, the studies, evidences have shown that beyond 34 weeks, with the definitive diagnosis of pre-eclampsia, delivery is safe for both mother and baby. Only we have to have a good NICU backup, and it also improves the outcomes for mother and babies, and it reduces stillbirth rate by 75%, and also gives a healthy baby to the NICU, because in expectant management, there is a risk of abruption, stillbirth, which can happen. So it is better that these patients who are confirmed pre-eclamptics, late pre-eclamptics, they can be delivered, but not necessarily as communicated by cesarean. We can induce, and there is a time to give steroids for the lung maturity, and it does not increase the C-section rates nor the neonatal admissions, which are of significance. So just to conclude that in LMICs also, which the Cradle 4 trial proved that the beyond 34 weeks, the planned delivery versus expectant management, planned delivery was more successful. And also this is an important aspect that counseling plays an important role in the counseling with the patient, her family members, because, and as well as our NICU backup should be excellent on this. With that comment, I conclude my remark.
Thank you very much, Dr. Ballard. And I would just add one small thing before we move on, if I may, which is, although the NICU backup is really, really important, actually, what we found with planned delivery is that there were fewer neonatal unit admissions. So I think wherever you are, actually delivering early when mum and baby are well is likely to result in a weller baby, regardless. But thank you very much, and thank you very much to Dr. Gitanjali and to Sister Josephine. I'd now like to introduce Rosalind Adjicum, who is an expert renal nurse, a patient advocate, a PhD candidate, and a woman with lived experience of preeclampsia, in conversation with Dr. Kate Bram, who is a consultant nephrologist and reader in maternal medicine, who's really focused on addressing the hidden burden of pregnancy-related kidney injury and changing the trajectory of kidney disease and cardiovascular health, particularly in women and in marginalised communities. Over to you.
Fantastic. Thank you, Alice, for that introduction, and lovely to see you, Rosalind.
Thank you.
We've already had an introduction, and we're obviously working together very closely. Rosalind has been working with my team leading community-based kidney health checks, but a hidden unknown about Rosalind was that she actually has her own story to tell, and you have a huge amount of lived experience and a lot of knowledge which guided you through your journey. Are you able to just start, if it's okay, just to tell the audience a little bit about your obstetric history?
So I've been pregnant 8 times and I have 2 children. My first 2 pregnancies were miscarriages, or what we call misdad. And afterwards, I became pregnant with my eldest son, 36 weeks. And then in between then I had 4 other unsuccessful pregnancies until I became pregnant with my last one, which is just a couple of years ago.
Thank you, Rosalind. And when we previously talked about this, you were explaining to me how important it was and is culturally to have a large family. Can you talk a bit about that?
So I had grown in a very large family, and children are seen as you being blessed, but also honoring your husband. So when you're married and after a while you don't have children, people start looking at questioning themselves. Is there a problem with the woman? It's interesting. They never look at the man though. It's always coming to the woman. Is there a problem with the woman? And I still remember my mother-in-law asking, okay, what's happening? My father-in-law asking, what's the wait for? So that pressure is there. When I got married at first, I could understand the pressure, but as I progressed, I didn't bother about that pressure anymore. I think by the time I lost the 4th pregnancy, I just thought, you know what? I thank God for one. I'm not just going to kill myself for another one. If it comes naturally, fine. But if it doesn't, there isn't anything I'm going to do about it. And if my husband was not pleased and wanted other children.
And can you tell me about your own health during that time?
So I had struggled with that pregnancy. As a growing-up adult, I've always had low blood pressure. I only got to know when I went into nursing school that my normal systolic was 90. So that is normal for me. And all throughout other successive pregnancies, I never had any issues with blood pressure until the last one. I understood the risk being pregnant in my mid-40s. I understood the risk. And I had started with a low blood pressure. But in my 2nd trimester, I started having a headache. It was during one of the clinic they had noticed that my blood pressure was very high, and I couldn't even understand that. So I was started on labetalol, And I took the labetalol all throughout the pregnancy until I delivered. At 37 weeks, I delivered my son. Afterwards, I still had high blood pressure until about 8 months afterwards before I was weaned off the labetalol.
Thanks. And can you tell me about that day when you had a planned delivery date, and can you tell me about what happened at that time?
I had woken up, I think the night before, I knew something was not right, but I just couldn't figure out. So I had gotten up to go and have a wee. In the bathroom, as I stretched my legs and I sat down, I realized, oh, sugar, what is that? So my legs were darker than the rest of my body. My legs were slightly swollen. And then I thought, okay, it's a planned CS today. I know I am the third on the list. I'm not saying anything to my husband because I know how that is going to come across. I'm not saying anything to my husband. I'll just go to the hospital as planned and I'm going to speak with my doctor. So when I got to the hospital, I saw the doctor and then I said, could I please have a word with you? So when I said, no, I'm in outside.
And why didn't you want your husband to know?
It is just the way we perceive things when it comes to childbirth and all the mystery and all the mysticism around it and a lot of myth around it. So me not having had children so the age difference between my eldest son and this little one is 19 years. So any other thing is going to be taken, okay, who is doing what, witchcraft, that, I didn't want that. I wanted the day to be perfect. I didn't want to dampen my own faith. So that is why I decided to take the doctor out. So when I explained to the doctor, I said, just have a look at my legs. And that, okay. So he came back and said, right, team, plans change. Rosalind is first on the list. Now everybody is looking and thinking, okay, they went out, but what was discussed? And I am pleased that the doctor actually took my recommendation and then decided to have me first on the list instead of waiting third. I don't know what would have happened.
So you had a gorgeous baby boy who is now divine, and I've met him. He is absolutely delightful. And tell me about what happened next.
So all I know is that I have come off the labetalol. My health is okay. Stresses of life with full-time working mom, looking after a young boy. And then I had challenges in my own marital life. So I think in between then, it is likely that I was not looking after myself, just focusing on the boy, until one day I was having a headache and I had gone to my GP. I was also having gastro problems. So I had been placed on omeprazole by my GP. So I had gone to the GP with the constant headache. So the GP checked my blood pressure and they said, oh, okay, Rosalind, your systolic blood pressure is around 140. I'm like, eh? He said 140. I said, no, that can be right. Well, it's borderline. I said, I'm sorry, it's not borderline for me. This is, I would say, possibly stage 2. He said, no. I said, please, doctor, I have been hypotensive all my life. My systolic has been 90. So this blood pressure you are seeing for me, he wouldn't. He was still insistent that this is okay. Well, thankfully, I had started hitting CKD. So I went home. I went to do my own urine dip. There I was, proteinuria, right. Phoned my GP the following day, and then I made the story up because I realized if I didn't do that, I was not going to get straight. So I made a story up, told him about my urine being foamy, that, okay, Rosalind, come in the morning. So I went in there, repeated the test, proteinuria. That is how I got started on amlodipine 5 milligram.
So we now have confirmed that you've got chronic kidney disease.
Yes.
And can you tell me, we think that there are a couple of risk factors in your history. Can you tell me about your own delivery, your personal delivery?
Interesting. So I was born at 28 weeks, so I am prematured.
And we know that that's an established risk factor for chronic kidney disease.
Yes.
It's something that perhaps our obstetrics but certainly our neonatal colleagues are less aware of, I guess. But we do know that the nephrons develop during that critical period after 28 weeks, up to 36 weeks. And so we're now kind of having an increased number of individuals that were born early that we need to start monitoring. And then just briefly, we haven't got much time left, but just to highlight what happened to you after your delivery.
After my delivery, I had no care. There was no follow-up for the pre-eclampsia. And it's interesting, even me delivering, and then within 4 hours, I had a nurse coming to me to say, Rosalind, we have to remove the catheter. And then I said, okay, I've delivered 4 hours. I don't have any urine in this bag. Why are you going to remove the catheter? It's a hospital policy. Why are you removing the catheter? It's a hospital policy. I'm really sorry.
So we think you had an acute kidney injury, almost certainly.
As a kidney nurse, I didn't need anybody to diagnose me. My legs were all swollen, they were darker, my blood pressure was sky high. And I had requested for my blood result and nobody wanted to give it to me. It was like they were afraid of something.
And you found that you had a raised creatinine and
Yes.
some abnormal liver function tests
Yes.
at that time, didn't you? And unfortunately, you weren't followed up afterwards until this period where you've subsequently been found to have chronic kidney disease. And we're very aware that there's an association between preeclampsia and end-stage kidney disease, because those are things that are very easy to measure. But now we're becoming increasingly aware of these pregnancy events contributing to damaged kidneys of young women, that we need to take action to follow up. This is a really, really important opportunity to be able to prevent people like Rosalind potentially developing the complications of chronic kidney disease if they've got risk factors. If they've had preeclampsia, particularly if they've had preeclampsia with an acute kidney injury, it's not a benign event. They're losing more nephrons, and we need to be following these women up so that we can prevent ongoing complications. So I think that that's our key message to everybody out there today. We want to raise awareness of the fact that preeclampsia and kidney involvement is not a benign problem, and that we need to take action to check blood pressure, check urine, check creatinines in the postpartum period until they recover, and then annual follow-up ideally for these women that are extremely high risk, particularly in low-income settings where the resources to deliver dialysis, for example, in the future are very, very limited. And there are preventative strategies that we can use. So again, pregnancy being used as a stress test to reveal potential future problems that we can actually treat early and have meaningful impact. Well, thank you very much, Rosalind, for talking. Amazing story. And you'll be pleased to know that Rosalind is extremely well now and her kidney disease is very, very stable.
Yes.
Over and out. Thank you. And next, I'm going to introduce Katie Kurt, who is a fabulous PhD student with King's College London. She's been doing a huge amount of work in Sierra Leone, and she is going to be introducing the next session. Over to you, Katie.
Thanks so much, Kate. I'd like to introduce Lena. Lena is one of our colleagues who is working she's an associate professor in obstetrics working across Gothenburg and in South Africa, in Cape Town, and in preeclampsia and the long-term impact of preeclampsia on the brain and the heart. So thank you so much, Lena.
Thank you, Katie, for that nice introduction, and thank you so much for the invite. I've been really enjoying my hours here in the webinar, and it was a very strong and powerful story from Rosalind, and a really nice introduction to my talk here. So I'm going to see if I can share my screen, if you can see that properly. Is that working?
Yeah, we can see.
Perfect. So I was invited to talk a little bit about what happens after preeclampsia. So we heard a little bit about that already here with Kate and Rosalind. And I'm going to talk a little bit more about both the cardiovascular effects, but also some neurological effects after preeclampsia. So I have no conflict of interest into this presentation. So I thought we'd focus on these 3 areas because there's a lot to say about consequences after preeclampsia. It's like an webinar in itself, but I wanted to shed some more light on in general the consequences for the heart and the brain after preeclampsia, and if all women with preeclampsia are at similar risk. And then in the end, talk a little bit about what can we do about it. So firstly, what are the consequences? This is a well-known, I think, picture for many of us, and these increased risks for different types of cardiovascular disease have been known for quite some years now and quite well established. So women with previous hypertensive disorders of pregnancy have a 1.5 to 4 times increased risk for heart failure, cardiovascular death, arrhythmia, stroke, chronic hypertension, and coronary heart disease after a pregnancy complicated by preeclampsia. Yet so, preeclampsia is not included as a screening factor when you screen for cardiovascular disease in the general population. In addition, and what is maybe not as known, and what some groups have been shown more recent years, are that women with previous preeclampsia are also at high risk of some neurological disorders after pregnancy. So women with previous preeclampsia complain of an impaired cognitive dysfunction months to years after pregnancy. And the interesting fact here is that women with eclampsia complain more about cognitive dysfunction, and if they fitted more than once, they have even worse scores on cognitive function scoring, which is a bit interesting. It might speak towards like an acute insult on the brain after eclampsia. Women with preeclampsia are also increased risk of vascular dementia and Alzheimer's disease, and more so vascular dementia, and that's later in life. But I wanted to dig in some deeper into migraine and epilepsy, which we recently shown also are connected to preeclampsia. So after preeclampsia, in particularly after eclampsia, women with eclampsia are more often diagnosed with a new onset seizure disorder, epilepsy, and that risk is increased around 5 times and occurs a few years to 10 years or so after pregnancy. So I think that it's important in order to help women after the pregnancy to understand that this might be connected to the preeclamptic or eclamptic event. Also, women with previous preeclampsia are more often affected by new onset migraine. And I have had a few patients coming to me with new onset weird headaches that they don't understand, and also might lead to that they are more absent from work, which we recently now shown in some unpublished data from Sweden, that women with previous preeclampsia are more often on long-term sick leave year 2 after pregnancy, when you should have been finishing parental leave and back to work. So it's almost 50% increase from normotensive pregnancies. And as you can see, eclampsia is more of a 2.5 times increased number of days compared to normotensive pregnancies. So I think this is also important, because some women feel that they are sort of lost somewhere in between. They are not really picked up by primary health care, and they have been told that your preeclampsia should be cured and you should be well by now. But just acknowledging that this might actually be connected to the preeclamptic event would, I think, help these women a lot and increase the understanding and increase the understanding of us as healthcare providers, that these women might need to be more on sick leave in years or the first year or 2 after pregnancy. Further, I also wanted to discuss a little bit more about these more short-term effects after preeclampsia. We heard about it shortly from Rosalind, and I want to emphasize that some of these things, like chronic hypertension, is not waiting 10 years until it appears. It occurs quite quickly. So this is a previously healthy cohort from Gothenburg here in Sweden, women who enter their pregnancy normotensive. And then we measure their blood pressure 1 year after pregnancy when they came back for a study visit. And of these women who came back, almost 30% were hypertensive when they came back for their 1 year visit. And the sad part in here was that 60% of these women were not on treatment or did not know about their hypertension. So most of these women in a Swedish setting go undiagnosed. And this has also been shown a few years previously in the British setting. So in this cohort, out of 211 women, 70 were hypertensive 1 year after delivery. So it's not sitting at numbers around 10-15% like we thought previously. This is very common. So 1 in 3 women with preeclampsia will be hypertensive 1 year post-pregnancy. And that's why it's really important that these women are followed up and that this hypertension is detected early in order to prevent later cardiovascular disease. So is all preeclampsia similar? This is a very old picture. It's 24 years old. And already then we knew that preeclampsia with preterm delivery had an increased risk of mortality. Here you see 25 years post-delivery compared to no preeclampsia in preterm delivery and preeclampsia in term delivery. So it seems to be that preeclampsia with preterm delivery are more adversely affected. And here we can see that with another outcome, which is the composite outcome of cardiovascular events, where women with preterm disease have an almost 4-fold increased risk for this event compared to women with late onset disease who have an almost 2 times increased risk. So it seems here again like women with preterm preeclampsia are at a higher risk of adverse events later in life. And my personal story was that I had 2 babies when I was pregnant, and I was also affected by preeclampsia, which is quite common when you have twin pregnancies. So I had to have a look at myself in our Swedish registers, because I couldn't identify myself with having a higher risk of future hypertension and cardiovascular disease. So we published this back in 2020, and then we looked at women with preeclampsia and normal pregnancies with a singleton pregnancy, and then with multi-fetal pregnancy. And we could see that if you had a twin pregnancy, you actually did not have a significantly increased risk for later cardiovascular disease. So there is also probably differences in pathophysiology. And I think knowing this and expanding our knowledge would be able to also give us more sort of individualized advice to these women who are at high risk, who are not, who should we follow up really closely, and who can be more said to be not at as high risk for future cardiovascular disorders. So lastly, I wanted to talk about, can we do something about this? So this is sort of the hypothesis that you start off with maybe a slightly increased risk for cardiovascular disease, that's green line, and then you have your preeclampsia, which is like a second hit to the endothelium, and then you have a next pregnancy with preeclampsia, and then you go on having cardiovascular disease earlier in life and more often than women with normotensive pregnancies. So can you do an intervention to decrease the risk after the first pregnancy, avoid maybe preeclampsia in the second pregnancy, and decrease the risk to get later cardiovascular disease? Well, there are not many studies, unfortunately. Most of the studies are observational, where you can see an association between lowering your BMI after preeclampsia, increased breastfeeding, and diet habits to be associated with lower cardiovascular risks. For intervention studies, there are not that many studies, and there are more short-term outcomes. You've seen in some intervention studies that women get improved cardiovascular disease knowledge, they get reduced physical inactivity and a healthier diet. You've also seen more steps daily in step counting, for example, and some studies have seen no difference in weight change. So we're still waiting for these larger studies in more long-term outcomes. But one important trial I think that we can already now incorporate into our clinical practice is give the women responsibility. So if you give women own responsibility to check her own blood pressure with support, they could see here in a group from UK that women who had self-monitoring of their blood pressure had a lower blood pressure at 1 year postpartum compared to women with general health or with a standard follow-up. So we should actually involve women in postpartum health and give them information and make them measure their blood pressure on their own to be involved in their own follow-up. And guidelines, we do have guidelines. We don't always follow the guidelines, but most guidelines say that we should measure blood pressure. This is one of our PhD students in our group who did this summary. We should screen for CVR, 7 out of 10. We should do lifestyle counselings, 5 out of 10. Some biochemistry, 3 out of 10. And yearly blood pressure was recommended in 7 out of 10, but no guideline recommended BMI. So I think guidelines also need to be updated, and we need to do what these women actually require to reduce their risks. So in summary, after preeclampsia, there is a risk of chronic hypertension, and that's a big risk, and that's a risk that occurs early, 1 year postpartum. Also cardiovascular disease, renal disease, as we heard in the last talk, diabetes, and neurological disorders. And different types of preeclampsia may carry different risk profiles, and we need to be better at risk stratifying women depending on the phenotype that they have had during pregnancy. And self-monitoring of blood pressure and inflammation might decrease blood pressure at 1 year follow-up and decrease the risk of future cardiovascular disease, but we need more intervention trials of this sort to be able to guide postpartum care in a better way. So that was all that I was planning to say, and maybe we have time for a question or two.
Thank you so much, Lena. So interesting, and thank you so much for fitting so much amazing information and keeping it to time. I have a couple of questions, if that's okay. So I guess this is probably one of the million-dollar questions about the work you're doing, but do you have any sort of theories or sense for future work about the kind of mechanism behind the neurological disorders and the increased risk after preeclampsia and eclampsia?
So I think that we need to look into neuroprotective treatment for these women. We do nothing as it is now, and we give magnesium sulfate to avoid eclampsia, to avoid women to fit, and we treat eclampsia, but we don't give any neuroprotective treatment for more long-term effects. So we need to understand what women are at risk for longer-term neurological disorders, such as new onset of seizures, migraine, brain fatigue, sick leave, and then target these women and give them neuroprotective treatment. Evaluate magnesium sulfate for long-term neuroprotection and potentially trial new drugs.
Thank you so much. I think I've probably reached my time limit, but thank you so much for being with us, Lena. We're really grateful.
Thank you so much for inviting me.
And I will now move on to introduce our next speakers for the next session. So we have Dr. Alice Hurrell. So Dr. Alice Hurrell is an NIHR clinical lecturer, and she's a senior registrar in Obs and Gynae at King's College London and St Thomas's. She is currently working on coordinating the NIHR APEC-UK Global Health Research Group, which is looking into placental growth factor in low and middle income settings, to be precise, India, Brazil, Sierra Leone and Zambia. So thank you, Alice. And then I'd also like to welcome Mrs. Koiwa Koilabi. So she is the founder of Action on Pre-eclampsia in Ghana. She is amazingly well placed to have this role, having experienced eclampsia and very sadly lost 3 babies to the condition. She found from her own experience that there was very little information for women who had suffered from pre-eclampsia and eclampsia, and was inspired to set up APEC Ghana. So I'm delighted to introduce the 2 of them.
Perfect, thank you. So I think we're recording. So Koiwa Chileshi, thank you so much for joining me this afternoon to have a little question and answer session to find out a little bit more from Koiwa and to really bring the voice of women who have had preeclampsia to the heart of this webinar today. My name is Alice Hurrell. I'm a clinical lecturer working on the NIHR APEC-UK program looking at placental growth factor in preeclampsia. Chileshi?
I'm Chileshi Babulabwalia. I'm a PhD student and research fellow at King's College London, working on improving preeclampsia management in low and middle income settings.
And Koiwa, if you'd like to tell us a little bit about you.
My name is Koiwa Koilabi. Greetings from Ghana. I'm popularly called Mama K here. I'm the Executive Director of Action on Pre-eclampsia Ghana, a maternal health NGO focused on addressing the issues related to hypertensive disorders of pregnancy.
Wonderful. Thank you so much, Koiwa, and thank you so much for making that time in a really busy week for you. First of all, if you could share a little bit about how preeclampsia has affected your life, and how did you experience preeclampsia, and what was the impact on your life and your family and your role in the community?
Well, thank you, Alice, for this question. It's interesting. 7 years down the lane, I've been sharing this story, and I'm honored to share it here again. So, myself, Koiwa, I have been pregnant 4 times. I lost 3 babies, and I have 1 surviving child. And I lost these babies because of preeclampsia, not just preeclampsia, but the various spectrum of preeclampsia. I've suffered eclampsia. That was the first one I had. I suffered severe hypertension. I've had health syndrome. I've had it all. And I have a surviving child who is 11 years and currently in school because I patronize quality care in a high-income country, specifically in the United States. And so for me, I always say that if I have a baby, it's because I did patronize a certain high quality care, but my own country, Ghana, is here to give me my baby. The first one was in 2012, when as a first time, pregnant woman, so naive, I was excited. I had all the symptoms. I went to the hospital. I was patronizing private clinic, but nobody said anything, And then 7 months on, about 28 weeks, I just had a fit. And then I was rushed to the hospital. All the private hospitals didn't take me, and there was a public hospital that admitted me in and did an emergency CS. Interestingly, on the way to that hospital, my ex-husband had called my mother and was like, Koiwa, this is something's happening to Koiwa. And my mother was like, oh, that's my disease. It was quite a shock because we didn't know that she knew of that condition. This repeated itself,
in 2013. At this point, I have gone through some form of depression, some sort of form of sadness, you know, being a first-time mother in a context that we live in Africa, where you marry, baby must follow. So for me to have that experience, my first baby was quite traumatizing. But luckily, got pregnant again in 2013. Patronized antenatal care for 5 months in Ghana, then mobilized some funds and traveled to the United States. As I said, that pregnancy went well, but I did still have pre-eclampsia at 30 weeks, but I was managed 37 weeks. So fast forward, you know, 2017, I felt, well, I've conquered this disease. I still have my baby now, so why not try more? And so I did. But of course, once again, there was not the opportunity to be able to get that sort of resources to be able to travel again. So I patronized the care in my country. Sadly, about up to, say, 27 weeks, this time I didn't even have any symptoms. All I did was to get tired. Every point in time, there was no headache, no bloating. And so I just checked my BP, you know, randomly in the 7th month. And then I had this, was 150/100, and I was admitted. I was on admission till the 4th or 5th day, and the 5th day they came to check the fetal heartbeat, and they couldn't see anything. And then the doctor came and confirmed and said, Koiwa, I'm sorry, but we've lost our baby. At this point, you can imagine I was quite traumatized. They tried to induce me to bring a dead fetus out, but induction has never worked for some women like us. So I had to be taken to that cold theater room. If you've been to the theater room, you know how very cold it is. And for me to be cut open again and to be brought out a dead fetus. So this was my 3rd cesarean with no baby to compensate my loss. It was at this point that during my 6 weeks postpartum recovery period, I was just in my bed. I'm all grieving and crying and sort of going through that mental agony of having to lose a baby for the 2nd time. I wanted to find out what's wrong with me. So I did my own research online, trying to find somebody to talk to. What is happening? Am I in it different? Am I a cares woman? You know, exactly what is happening? Because I started a journey with a few people and they've had their children. Why me? In doing that, I didn't find any patient group. All I found was academic publications, but that was not what I was looking for. I couldn't even understand what was in there. And so I expanded my research, and then I found a patient advocacy organization in Australia. And with them, I began to have a conversation, and they helped me during those few weeks to be able to really appreciate that I was not alone. This is a condition that is affecting most women. So after that, I got back to them and I was like, you know what? I was looking for something similar in my own country. I couldn't find it. With your permission and with your blessing, I would like to replicate something similar in Ghana. And that is how APEC Ghana was inspired, where I went on radio station, my first radio station, and spoke about the experience. And then I had a lot of survivors coming on board. I had husbands who had their wives who had it calling and coming on board. Pre-eclampsia, it has a way of silently and yet very cunningly taking away from you what belongs to you. And so for me, it impacted my marriage, you know, because the husband didn't appreciate what was going on. My mother apparently was a survivor. I didn't know. And it was just a puzzle. What kind of condition it is? You know, and so this puzzle just kept us anxious because really we wanted to have more babies. I want to have more babies today, but I can't because I've had 4 cesareans, and because that is too much for my body. But it has denied me of that right to be able to have as much children as I want. It has denied, you know, my family for being able to benefit from that. And then talk of the mental agony. You know, it's like going on a journey. When you go on a journey, you expect to be going forward so you get to the destination. But pre-eclampsia just keeps you in circles. You get to, in my condition, I went 7 months, then something happens, then you lose. 7 months, then something happens, then so you just keep on going in circles with a sense of stagnancy without moving forward. And so it is really a cruel condition, and it impacted me a lot. Today, if I'm speaking about it and smiling, we've been through a lot, and that is why we do what we do. It was not an easy thing. And having to let people appreciate what this condition means, let alone the economic burden that comes with it. The last pregnancy where I suffered this, the medication was just too much. The hospital visits was just too much. The diagnosis, every 2 weeks at a point, they had to do some diagnosis to check where my blood level work and other things were. So pre-eclampsia has had a severe, a very much harsh impact on me, and I know there's a lot of survivors there like that. But I always say that if I'm the worst case scenario of what hypertensive disorders can present itself, then my country, Ghana, is yet to find a solution, because my story is on the fact that I have a child. I am a mother today because I patronize high quality care outside the country. Thank you.
Thank you so much. Thank you so much, Koiwa, for sharing that powerful story and your experiences. It's a really, really compelling testament to the need for quality care. May I ask, what were the biggest challenges you faced in getting timely and appropriate treatment for preeclampsia?
So one of the biggest challenges was, for me, with the first 2 pregnancies, because I patronize private healthcare. Private healthcare is more like out-of-pocket expense. So if you have money, you get the care quickly, right? If you have money and you're able to pay the out-of-pocket, then it means your access to care will be faster. If you don't, and you go to the public setting, then you can be sure to be in the long queues, to be in the delayed schedules, among many other things. And somebody said, care, no matter how good it is, if it's not by the timely, it is useless. And so in my situation, yes, I was able to patronize private quality care, but this is it. In a private setting in Ghana, the practitioners, the specialists you have there, they are all not full-time. They are doing what in Ghana we call local. So they come there after they have sort of played their role in the public facility they serve at. So when I go to a private health facility, maybe at the time that I had this eclampsia fit, and I needed an emergency CS, there was no way there was going to be a doctor on site, on call at 2 a.m. to be able to perform an emergency cesarean, because it's a private facility and they don't have that kind of 24-hour service. And so in my case, the first 2 private hospitals they took me to did not admit me because they weren't ready and could not be able to handle it. It took a public facility to do that, okay? And so that is sort of the dynamics of what it is here. But then if you go to a public facility, if there is this long wait, which I did experience, if there is that delay, you can be sure that at any point in time, whatever happens, there is a specialist or somebody there to provide that care. The number is there, the quality of the specialist, they are all there, but that is not the same with the private health facility. So my experience was, yes, I was excited I could do private, but at a point, I realized that the care was not so comprehensive, I would say. And it wasn't so, as expected. And the resource persons were not there. But with the public one, they were all there, but there was always an issue of long queues, long waits. You can be sure that if you're going for antenatal in the morning, you probably return around 3, 4, 5 p.m. Which pregnant woman is comfortable being in the hospital the whole day just to receive antenatal care? So these are some of the challenges. So it is an issue of economic factor. It's an issue of the various kind of systems in place to provide that care.
Thank you for that. And you spoke briefly about going on the radio and telling your story and having feedback from other women in Ghana. How do women in Ghana talk about their experiences with preeclampsia? Is it considered taboo? Do women feel like they understood what happened to them?
So it was very interesting. So the thing with our women in our context here, they really have a lot to say, and they'll probably say it, but they would love to say it behind the scenes than show their face. And so what happened was, after the radio show, I had a lot of all these women call in. That was when we started a WhatsApp group. People started sharing their stories. At a point, I was like, we need to put a face behind these stories, because that has a way of moving the ethos, the emotions of people when they see that this is a real human being. But then I realized that most of these women were willing to share, one, either with the husband's permission, two, share but not show their face. And also three, some were reluctant because it was more like, I don't know if I should use the word taboo, but we live in a context where the belief is, let's speak more about the positive things and speak less of the negative things. So for me, for instance, I had a backlash a few times when I went to the radio from even some health practitioners and some people who were like, what are you doing? Why do you go on radio and speak about these negative experiences? Do you think pre-eclampsia is a new disease? It's an old disease. You're lucky you're alive. What makes you think US people don't die there? You are just lucky. So I did receive a backlash because I was being too vociferous and detailed about the experience. And so for me, I'm like, it's and I knew what I was getting into, and I have learned over the years the context that I am in. But then most of our women are not willing to share because If they want to share, it means it involves their husband. Clearly, the baby was made by two, so the story would involve their husband. And sometimes they need to seek their permission, and sometimes they don't get that. Those who also really want to share, even if they don't get the permission, will not want to show their faces. So that is the dynamics there. So it depends, and mostly the low sort of economic people, they would want to talk about it, but oh, don't mention my name or anonymous, that kind of thing. And then there's also the high, most of the upper middle income who would want to share and sometimes mention their name or show their face, but then with certain conditions. And so along the line, when we try to produce a documentary with real life stories, which I don't know if you watched, but we have a documentary, Pre-eclampsia Diaries 1, it's on YouTube. It was a struggle to get these women because they want to say it, but they don't want people to know it's there because they don't want the stigma. I mean, at a point, you get that thing where people are like, this lady, she's always losing babies pre-eclampsia. So people don't want to associate with you when they get pregnant. So they think it's a disease that you can pass on, whether by being a friend. So it's all that kind of dynamics, yeah.
Well, thank you, and thank you so much for sharing your journey, and just amazing all of the work that you're doing, to really raise awareness and to get to better care for women and families affected by preeclampsia. So, if you could tell healthcare workers and researchers and academics working in this sphere, one thing to improve the experience of women like you, what would it be?
I think I always say that not everybody can be a professor, not everybody can be a researcher, not everybody can be a doctor. But one thing is for sure, everybody will be a patient, irrespective of who you are. And so in the field of providing your care, in the field of research, in the field of being an academician, remember and ask yourself, if you were a patient in that condition, what kind of care would you want to receive? Because that is the kind of the care that you are promoting or advancing. That is what will be given to you. And so all we are saying is that they should listen to the women. They should remember that they can also be that patient, that mother who suffers this condition, or their sibling, or their sister, somebody who suffers their condition. And they should just ask themselves, what kind of care will they want they or one of their own to receive? If they are guided by that, then I believe that they'll be guided by that in providing their care or in advancing their research or in any other related course that they pursue.
Thank you, Foiba. Thank you. Really, really impactful for all of the people listening to the webinar to hear. So thank you so much for your time.
Thank you for the opportunity, and wishing us all the best in this journey.
Thank you.
Well, thank you very much for that, and particularly to Kwana for that really very powerful story and emphasizing the importance of advocacy and hearing the woman's voice. And the thing I found most compelling is the fact that she could draw in from other women who've suffered, who felt they were on their own, but actually coming together as a single group, understanding and supporting each other. It's a very powerful message to give out. And I think it leads on very nicely to the next session, where I'm going to introduce two very remarkable women. And first of all, Sister Betty Sam, who's a midwife leader and a national icon in Sierra Leone. She has trained thousands of frontline health workers, partly through the CREDO program, which has gone on and helped to save countless lives. And she was named as one of the top 100 nurses and midwives globally, and just last week received a Lifetime Achievement Award, the Service to Nursing, Midwifery and its Mothers of Sierra Leone. Alongside her, we're delighted to introduce Dr. Candice Buku-Betts, a passionate maternal health advocate and PhD researcher, and she's currently exploring the biological and social mechanisms behind why preeclampsia is so severe in teenagers, a very important area since teenage mothers account for about 40% of all maternal deaths in Sierra Leone. So we're both happy, we're honored to have both of them here today. And the title of their session is Belly Woman for Die, which actually translates into Pregnant Women Should Not Die, a call for action. So I pass on to these two wonderful women to take this session.
Welcome. Today, on behalf of the Cradle 5 team and the Wellborn Partnership, I have the immense honor of speaking with Sister Betty, a globally recognized nurse and midwife, a matron during the Civil War, and the driving force behind training thousands of frontline health workers to save mothers' lives in Sierra Leone. Sister Betty was recently awarded the Lifetime Achievement Award and voted one of the top 100 nurses and midwives in the world. She has been with Cradle from the very beginning, and we welcome you, Sister Betty.
Thank you, Jenny. Hello, listeners and viewers.
So, Sister Betty, you have been with Cradle from the beginning, and you have been leading the Cradle training since, I think this was 2020 or even 2019.
Yeah.
What does this program mean to you personally?
My involvement in this program ever since, it's a huge opportunity for me as a retired person to come back and work with my colleagues and build capacity in especially the obstetric emergencies like preeclampsia, shock, to feeding and all of that. I'm happy to be back.
Thank you. I'm trying to speak on behalf of everyone when I say we're so glad to have you back. You've made such an impact in all of our lives. Thank you. So Cradle is now being integrated into the National Midwifery Training and EMOG programs. In your view, what makes the Cradle device and training approach different from other interventions that you've been part of?
So just to show this piece of equipment that's called Cradle, it's very powerful. It's what we are using. It has traffic light system that gives early warning sign, and then it also has arrow up and arrow down when the blood pressure is up and when the blood pressure is down. So this piece of equipment has been integrated into EMOG training in the country and midwifery training for the simple reason that midwives are the frontline workers in obstetric emergencies. So if they are trained in Cradle, then they'll be able to recognize, use it properly to recognize preeclampsia, to recognize shock, and help save the lives of the mothers and their babies.
So you talked about preeclampsia. It remains one of the biggest challenges in maternal health in Sierra Leone. What makes it such a difficult condition to tackle, and why is awareness so important?
It is a difficult condition to tackle for the simple reason that preeclampsia itself doesn't show all the signs and symptoms. So it could be there from the start of the pregnancy, and then no one knows if the women are not coming for their blood pressure monitoring. It's a silent morbidity, silent killer. So because of that, awareness raising among healthcare workers, training them on the Cradle, and also involving community stakeholders, male partners, and all of that has been a huge benefit because a lot of people now know about preeclampsia and they know what to do. So this is what we have done, and we've advocated a lot of it.
Thank you. So we are marking World Preeclampsia Day today. Can you tell us what's happening in Sierra Leone this year? What messages you'd like to send to women, families, and health workers?
So for this year, the World Preeclampsia Day, we chose awareness raising as the theme. So we've gone to several media houses to send messages to everybody, to the community, to the population at large. We've gone to military school in Western area, trained the tutors and their students, and also commerce
the College of Medicine, medical students. Today, there will be a football match organized by Lifeline, Neymar program, because they are the ones that are participating in the community activities. So we'll be there to to witness the football match. And during the football match, messages on pre-eclampsia, raised blood pressure are being sent out so that men will be there. Many men will be there. So this is what we are doing.
Yeah. So I guess, yeah, like you said, the football match is a good opportunity to capture young people as well as men.
Yes.
And brings awareness. And I know you did some screening in the National Health Summit that happened last week as well.
Yes, the team was there to do a lot of, and then this is all part of the collaboration so that people know. And because of the great work that we are doing in Cradle, we have the opportunity to be involved in the construction, saving lives construction, working in 6 districts and doing training and supporting supervision.
So finally, Sabeti, before we go, you're helping shape the next steps through a program called Papaya. Can you tell us a bit about it?
Papaya came about from Cradle. So it's mainly raising awareness, educating the women and their partners and the community for the women to come and obtain antenatal service as soon as they know they are pregnant, so that preeclampsia could be detected early and gently before it causes complications of raised blood pressure affecting the brain, affecting the eyesight and liver and all of that. So papaya is mainly coming to the clinic early and then using the cradle to detect the raised blood pressure and also looking at protein in the urine. So therefore also we were able to support some facilities with logistics.
Thank you so much. So you've heard Sister Bensi, early detection and awareness are key to tackling this preeclampsia issue. So thank you so much, Sister Betty, for your wisdom, your courage, and your lifelong service to women in Sierra Leone.
Always a pleasure.
And thank you for reminding us about what truly sustainable innovations look like. It starts with trust, training, and people. Thank you.
You're welcome. Right, everyone. Wow, thanks so much. It's I feel incredibly privileged to be in the same lineup as all you guys, and what an incredible just big thank you to everybody who's taken part. Just before we finish, I just want to finish with what was a very exciting initiative, and I'm so glad we did it. We launched a Cribs Global Creative Competition following what was an unbelievably successful poem that we came up with last time we had a competition like this. And the idea was to share your voice on pre-eclampsia. So it was an open invitation to anyone affected by pre-eclampsia, and it could be personal experience, story of someone you know or love, either through work that you do in healthcare or whatever. And it could be poem, paintings, photographs, reflections, and anything you like. So we had a fantastic response, even though this was done fairly last minute. And I'm just going to announce the winners. We really didn't know how to put clear water between the runners up. So we've actually going to honor 3 runners up. So just in no particular order, the midwives from UTH in Lusaka, Zambia, who I think did a phenomenal poem. Shriva Sudadi, who did some art from India, and Moses Gamba Maboya, who did a beautiful poem, who's based in Sierra Leone. Just wanted to say thank you. And what we'll do is we'll put these on the Cribs Global website so people can view them. But our winner, who was outstanding, and we had a chat with her earlier today to tell her, was Nana Kamara for her phenomenal poem, and she's based in Sierra Leone. And as many of you, she's actually busy working all day. We did invite her to come and recite her poem live with you, but she literally is kind of busy saving lives. So we will stick that up, but just wanted to acknowledge all the contributors, and I think it's really important to get people's views, particularly in this arts way. So I'm just going to say thank you for everybody. I think we should just reflect on the fact that we know preeclampsia is preventable, it's detectable, it's treatable. We need to impact everybody, from policymakers, providers, participants, patients, parents, whatever. And I think the thing for me about preeclampsia is it's devastating, but it's just avoidable if we all work together. And I think we should all just strive to prevent people dying as they give life, because it's just wrong. And this is tough, but definitely winnable. So thank you all. Keep going. We're all on the same side trying to achieve the same thing, and we are making progress. So thank you for supporting this webinar. Thank you for supporting APEC and Cribs Global, and let's keep working together. Have a great evening.
Thank you all very much. It's been a tremendous evening. We've had several hundred of you here throughout. Thank you for your insights, to all the panelists. Thank you for your questions. And we look forward to seeing you again and working with you more closely in the years ahead. Thank you all very much. Have a good evening. Cheers. Bye-bye.